Okay. Devin, I have one student who might need your help. I'm going to ask them to direct message you.
Sure.
Okay. All right, everybody. Let's go ahead and get started. We are going to be recording the session so that you guys will have the ability to review after you graduate and while you're studying for NCLEX. So just to let you know that, I know that that's always a question I get right off the bat usually, so I just want to answer that now. You all know me, so I won't, obviously introduce myself again, but I do want to say that I'm really very excited to be doing your NCLEX review course with you all. This is something that Linda and I have started doing in the last maybe year and a half or so for students here at UNLV. We used to have HESI come and do a review course, but Linda and I both feel really, passionate about doing this work with students, and with UNLV being kind of our home, we thought that, why don't we do this for the UNLV students? And so we're both really excited to be able to do this. And we're looking forward to the next 3 days. It's going to be jam-packed with lots and lots of important information. It is critical that you guys attend all 3 days and that you are listening throughout the entire presentation. So that's kind of just a quick, brief intro before we actually dive in. But before I start, since we have Linda here, she's not presenting today, but you guys will have the opportunity to hear from her tomorrow and on day 3 as well. But I want to just say that Linda we're really lucky to have her. And I'm not saying that just because she's my family, but we are really lucky to have her because she has such an extensive career in NCLEX prep. And I've been really fortunate to work alongside her for the last several years doing this. And so it's really just a unique opportunity to have her doing a portion of your review course. She has been doing NCLEX prep courses, and then also you probably recognize the review products as well. And so she is truly an expert in NCLEX prep. So Linda, do you want to just say a few things?
Yeah, I don't want to take up a lot of time because I know that the days are tight. But I just want to say that it's great to be here with you and to work with all of you and, listen to everything all of the faculty have to say today. And we'll be talking, Angela and I'll be talking more with you at the Q&A sessions. I'll be at the Q&A session later today and around all day. So if you have anything that you'd like to ask me, but as Angela said, I've been doing NCLEX preps for years, and I won't tell you how long, but for years. And it's just great to be here with you today. So I will be going over some things tomorrow with you. I won't take up a lot of time, but I will be here all day and at the Q&A session later today. So any questions you want to ask, just please feel really free and comfortable to ask them. Okay? Thanks, Angela.
Yeah, thank you so much. And so as Linda said, this is kind of informal. And so whatever questions as we're going along you guys want to ask, you can put them in the chat. You can unmute and start talking. You can raise your hand. I'll ask Devin to kind of help me monitor that. And so we want you to ask questions along the way rather than waiting until the end and then maybe you don't end up asking it. So please feel free to do that. So before we get started, is there anything that you guys want to ask now? Any questions that you have at this point in time? Just a couple friendly reminders that aren't related to NCLEX review. We do have course evaluations open for 427. So please go into your Rebel mail and access the course evaluation and get that done. That would be fantastic and much appreciated. And then secondly, we have our sexual assault training, Dean's lecture series today at 4 o'clock for those of you that are interested in going. All right, so without further ado, we're gonna go ahead and get started. So NCLEX, did I hear somebody on mute? You guys, does someone have a question? Okay, perfect. All right, so NCLEX. So you guys recently took your HESI exit version 2, and I took a quick look at those results, and I'm gonna go into more detail on that on day 3. But what I do wanna say is first, there was improvement, and I am really happy about the fact that there was improvement. But you guys aren't ready yet to take the NCLEX. Okay, you're not quite there yet. And so what I really want from these next 3 days is that you're spending time really listening and thinking and learning so that when you go into CAT at the end of the week, hopefully we'll see further improvement at that point in time. And then after that, between that time and the time that you take NCLEX is really a key opportunity for you guys to be studying and to go in there being confident and prepared, because just, you know, based off of the aggregate result, you know, not as an individual, you guys can interpret your own individual scores to know if it were me and I was the person graduating and getting ready to take NCLEX, based off of the results that I'm seeing, you should not quite feel ready yet. Okay, so I want you to take that really, really seriously. And happy to answer questions individually on that at any point in time, just let me know. But you've got lots and lots of resources that you can use to help you to be ready for NCLEX. All right, so just a quick disclaimer. The content of this presentation and the practice questions were taken from a number of our Saunders review resources for the NCLEX exam and Elsevier. All right, so we're gonna just dive in, do a couple of warm-up questions. This is gonna be a question and answer based review, where we will do lots of discussion. We're gonna kind of walk through rationales and walk through the thinking process that you guys should use when you're answering questions on the NCLEX. But we're gonna just warm up by diving right into some questions. So what I'm gonna do is I'm gonna read the question and the options, and then I'm gonna launch the polling, and I'll give about 10 seconds to answer each question, and then I will display the results. A client is experiencing a hypoglycemic reaction. The nurse would administer which item to the client to treat the reaction? 1, milk, 2, water, 3, diet soda, or 4, 1, sugar-free cookie. Okay, looks like that was already launched. You guys are answering that.
I'm sorry, Dr. Silvestri, how do we answer this, or are we just putting it in the chat?
So you should see a poll. So I'm gonna, for those of you who answered, I'm gonna ask you to answer again. I'm gonna relaunch it. Okay, so I'll ask you to just answer again. And do you see that? You should
I
be
do,
able to.
thank you. Yeah,
Perfect,
thank you.
you're welcome. All right, so I gave just a little more time since that's the first question. And once we get into the groove of doing this, I think you guys will get a little bit quicker. So, all right, so it looks like, so 71% of the group wanted to go with option number 1. And then a few of you wanted to go with diet soda, and then a few also with the sugar-free cookie. So let's just kind of talk about that a little bit. So first things first is that we are saying here that the client is experiencing a hypoglycemic reaction. So one thing that's really important whenever you have a question about blood sugar and about hypoglycemia, you want to be sure that it's confirmed by a blood glucose reading. That's really, really important. And if you do have a confirmed hypoglycemic reaction, the next thing that you need to do is going to be to administer glucose, whether it is a rapid releasing form of glucose in the form of like a food item, like in this question, for example, or perhaps it's following a protocol where you're administering glucose in the form of a medication. So just kind of keep in mind that confirming hypoglycemia is really important so that you know that you're treating what the actual problem is versus potentially making it worse if that's not what it ended up being. Hypoglycemia and hyperglycemia have very similar symptoms, so it's important to confirm one way or the other. If you confirm that it's hypoglycemia, you want to administer glucose immediately. And in some settings, it does mean giving food items to treat it. So you want to administer rapid releasing glucose, followed then by a complex carbohydrate and a protein. Hopefully you guys remember this from PEDS. I know that you have a simulation that's on this. So what is an example of a rapid releasing form of glucose? It could be the following: half a cup of orange juice, sugar sweetened carbonated beverage. So that's why the diet soda is wrong, because it has to be like a regular soda. Could be 8 ounces of milk, which is the correct answer in this case. And I just want to say that that's not the most obvious correct answer, I don't think. And this was something that we learned was actually a question on the NCLEX exam. Other things that you could give: a small box of raisins, 3 or 4 hard candies, 4 sugar cubes, 3 or 4 lifesaver candies, a candy bar, teaspoon of honey, or 2 or 3 glucose tablets. So those are just some examples of the rapid acting glucose, rapid releasing glucose. And then again, you want to follow that with a complex carbohydrate and a protein. So you could do like slice of bread or peanut butter cracker after that. And that's to prevent another sudden drop in the glucose. All right, nice work with that. This diabetes is going to be something that you're likely asked about on the NCLEX. So this is something you want to be really familiar with. Remember that the way that NCLEX is designed is it's designed to test you on the concepts that you're most likely to encounter in your first year of practice as a new graduate nurse. And so what you'll kind of intuitively or logically expect is that you will have questions on conditions that are more common. And so diabetes is definitely one of those. Since we're talking about hypoglycemic reaction, I think it's a good thing to just talk about kind of what the steps would be to manage something like that for somebody who is hospitalized. So first thing, like I said, is you're going to check the blood glucose level. If you confirm that it is in fact hypoglycemia, you want to give them that rapid releasing glucose. And then you want to check vital signs as well, right? You want to give that longer acting carb with the protein. And then you always want to reassess because you need to make sure that your interventions were effective. So you need to retest the blood sugar level. And then after that, you're going to document. So that's what you want to do in that case. All right. So we'll go ahead and move on. So we have another question here. The nurse administers 10 units of insulin aspart at 0700 hours to a client with diabetes mellitus. The nurse would monitor for hypoglycemic reaction during which hours? And I'm just going to let you guys read those options. pull up the polling here. All right, so 81% wanted to go with 0900 to 1100. So we're administering at 0700. So then you're thinking that 2 to 5 hours later is when you would monitor for a hypoglycemic reaction. So that's good. That's the answer to this question. So nice work with that, you guys. And I'm going to actually move on to the next slide to show you this table. So with insulin, you have different types of insulin, and they're categorized based off of kind of their time course of activity after it's injected. So you have first your rapid acting, which, as you can see, insulin aspart is considered a rapid acting insulin. And so when we talk about insulin and the timing of it, there's 3 things that you want to consider. It's the onset, the peak, and the duration. So the onset is in minutes. So this is when you expect the insulin to begin working. So in the case of insulin aspart, it begins working in 10 to 20 minutes after administration. So then the peak is going to be in 1 to 3 hours. Okay, so peak meaning that is when you would expect the insulin to be at its maximal effect. And then the duration, it lasts 3 to 5 hours. So if we were to look back then at this time frame, so what did we say? We said 2 to 5 hours here. So you can see that that is the best time frame to cover both the peak and the duration of the insulin. You're most likely to have a hypoglycemic reaction during the peak time, but it could happen at any time during the duration of action for that type of insulin. So you want to just keep that in mind, and it really is dependent too on their intake and what they're eating before and after administration of the insulin. So kind of in general, I would highly recommend for each of these categories, rapid acting, slower acting, intermediate, and long, just have a general idea of the peak in particular, and it's helpful to know about the duration as well, okay? With the long duration insulin, so your insulin glargine and your insulin detamere, you can see that with the glargine, there's really no peak. And then when you talk about the detamere, so this is your Lantus and your Levemir. You might know them by those names. When it comes to the peak, it's like either there is no peak or it's a long time after administration. And so usually you don't worry as much when it comes to hypoglycemia with these insulins. So, and you've probably noticed in practice, we don't dose any sliding scale insulins based off of our long duration insulin. Okay, so keep that in mind. Long duration peak is either really long or there is no peak, and it typically works over almost the entire day. So yeah, just kind of go one by one. So rapid acting, slower acting, intermediate duration. NPH is your only intermediate duration insulin that you have, and then your long duration. Put a note there to kind of study those and have those in your mind. All right, next question. The nurse notes that an assigned client will receive a unit of blood. The nurse prepares for the procedure and plans to check which priority item prior to the procedure. Are we going to do skin color, vital signs, urine output, or peripheral pulses? All right, so majority of you guys wanted to go with option number 2. You guys are doing really good with these warm-up questions. I will say they're warm-up questions for a reason. They're a little bit easier, but I'm glad that you guys are doing really good. That's awesome. So option number 2 is the correct answer. And I think it's a good time because blood transfusion is likely to be on the NCLEX exam to kind of go through some of the major considerations around blood transfusion. So let's just talk about some of these general principles. So first, you can infuse a large volume of blood if necessary, right? If somebody is hemorrhaging, they might need a really large volume of blood to be infused rapidly. It's ideal to do that through a central venous catheter. Okay, so just keep that in mind. If that's an option, that's the best way to do that. No other solution other than normal saline should ever be administered together with blood components. So, and that has come up as an NCLEX question. That's something that we have learned, is that might be a concept that you guys are tested on. So if it ever says, you know, administer the blood with 5% dextrose and water, or administer the blood with lactated ringers, or whatever the case may be, that would be an incorrect option, and you would want to eliminate that option. Only normal saline, that's the only thing that blood can be administered with. Medications are never added to blood components or piggybacked into a blood transfusion. You never want to do that, and you'll never see that done in practice. You might remember from way back when we did our test taking strategy session, we talked about avoiding the risk of septicemia. You want to give units of blood within the prescribed time frame for administration, whatever the unit policy is. Typically, it's 2 to 4 hours for packed red blood cells, so no longer than 4 hours from the time that the unit of blood is picked up from the blood bank to administration or completion of administration. But really, if you're getting the blood from the blood bank, what you've done is you have arranged all of the other things that you need to worry about around that. So you're getting it and you're giving it right then and there. There wouldn't be a reason to get it and then wait 4 hours. The administration set, so if they have to have more than 1 unit of blood, should be changed with each unit of blood, or according to the agency policy. But typically, you know, you take the blood bag down and you discard the entire administration set along with the blood bag. You will check the blood bag for the date of expiration. Some components expire at midnight on the day marked on the bag. So you have to be really vigilant and careful to make sure that it hasn't expired. And that's part of that double check process when you're giving blood. You want to inspect the blood bag for leaks, for any abnormal color, clotting, or bubbles. You have to, as I said, give the blood as soon as possible after getting it from the blood bank. And you never want to refrigerate it in refrigerators other than those used in the blood bank. So let's say you get the unit of blood and then something comes up that you have to take care of first. What needs to happen is you need to ask somebody to bring the blood back to the blood bank for you, so that you can take care of whatever it is that you need to. You don't want to just put it in the unit fridge. The recommended rate of infusion of blood depends on the components of the blood and the client's condition. So generally, it should be given as quickly as the client's condition allows. In my practice, what I would do and what I would see other nurses do is they would start it at like 80 mLs an hour. They would come back when they're doing their vital sign checks, and we would see how they're tolerating it, making sure they're not showing any signs of circulatory overload or allergic reaction or any other type of reaction, and assess their vital signs, make sure those look good. And then we would increase to 100. And then we might go up to like 120. And then that would typically be as quickly as we would go, but the policy, the unit policy will tell you exactly what you need to do. So with the vital signs and lung sounds before the transfusion, and again, after the first typically 15 minutes, and then every 30 minutes to an hour. And you assess vital signs up until 1 hour after the transfusion is completed. So I'm just going to address just a question that I got in the chat. So what do you check when you have the blood? Again, you check for leaks, bubbles, and what else? So what you want to check for is, and you kind of hold the bag up actually to the light, just very carefully, and you check bag for any leaks, which would actually be pretty obvious. Any color that you're not used to seeing with the blood. You want to look to see if there's any clots in there, and then if there's a lot of bubbles. What the bubbles are going to do, it's going to cause problems with administering it, and it's just going to tell you that there's air in the line. And so if there's a lot of bubbles in it, you may have to let it sit and rest for just a little bit, or if that doesn't work, you might just need to get a new bag. And then there was another question that came in the chat. Why couldn't you administer blood products with other isotonic solutions? So I think that's a really good question, because normal saline being an isotonic solution, it's like, okay, so we can do it with that one, so why couldn't we do it with other isotonic solutions? So that's a really, really good question. And I'll be honest, I don't know the exact answer as to why we couldn't do it with other isotonic solutions. When it comes to other types of solutions, though, what does end up happening is that you can end up with kind of this clotting that occurs if it's given with other types of solutions. And so that's in general the recommendation why we do just normal saline. Sitting here thinking about it, I would say reasons why we don't do it with other isotonic solutions besides normal saline. So normal saline really is mimicking, it's like a synthetic version of body fluid. And so it just makes the most sense to administer it with that. And then you don't end up with that issue of, these components mix, and then you end up with kind of this substance that, first of all, isn't easy to administer, but then it's not going to work. So I think that's a really good question. And I think probably the answer is because it mimics body fluid. All right, let's see what else. So we talked about vital signs and then lung sounds. So remember that circulatory overload is one of the things that can happen. And you guys are going to take care of patients that are in a really kind of dynamic state where, they could have certain comorbid conditions that would place them at risk for this complication from blood transfusions. So you have to be careful, but then at the same time, they need the blood, right? So let's say, just to give you a quick example of this, somebody who has history of end-stage renal disease, heart failure, these things often do co-occur, but they're anemic, which, anemia of chronic disease often occurs with end-stage renal disease, but let's say it's to the point now where they're symptomatic and they do need a transfusion. A lot of times we don't transfuse patients with end-stage renal disease, but if it does get so low to the point where they're symptomatic, then they might give them a unit. So you have to be really careful, because you are now giving them, this fluid, and so you have to watch for signs of circulatory overload. And so looking at listening to the lung sounds and monitoring that is really important. That's one of the areas that you would see it manifesting initially, and then, of course, with heart rate and blood pressure as well. Um, okay, so cultural religious beliefs regarding blood transfusions, you have to assess for that. That's part of the consent process when you have them consent to receive blood transfusions. A Jehovah's Witness cannot receive blood or blood products because this particular group believes that receiving a blood transfusion has eternal consequences. So you'd want to be really careful about that, and you'd want to assess for that during the consent process. You'd obviously want to explain everything to them, determine whether they've ever had a blood transfusion in the past, and then also ask about any prior reactions to blood transfusions, because if they have had prior reactions to blood transfusions, then there may be something that we'd want to do to prevent that with the current transfusion, for example, giving Benadryl or diphenhydramine prior to.
Hey, I had a quick question, and this is regarding consent. There was a question on the test that we just took that said if like a person came in and like they were unconscious because of severe trauma, and it was regarding consent, and the correct answer ended up being that you would get consent from the friend. But like when somebody comes in and they're like, oh, we're a friend, they might not even know them. So wouldn't we just perform like life-saving procedures? Because I mean, at the end of the day, if the friend was like, no, actually, I think they're good, like, let's just not do anything, are we actually going to adhere to that? So in that purpose, wouldn't the consent just be nulled anyways?
Yeah, that's a great question. And what we're talking about here is emergency consent. And so typically it does depend upon the facility that you're working in. Like that's always a disclaimer that I have, because there are different policies in different places that you're going to work. But typically the way that this works is that if it's a life-saving intervention and you don't have the next of kin, like the spouse, or if the spouse isn't there, then whoever the next of kin is, or their designated power of attorney, like if you don't have any of those people there, then I would say, I would agree with you on that unless the friend was designated as, their guardian or their power of attorney, and you were able to confirm that, which is probably, maybe it could happen in an emergency procedure if they're really well prepared for an emergency situation. But just in general, without that wouldn't be the person that you should get consent from. And the way that emergency consent works is that if there isn't any information that explicitly says not to take those emergency measures, for example, a DNR bracelet or something like that, or paperwork that they happen to have with them. Some people have those things with them like all the time, because they want people to know in the event that something were to happen. So if there isn't any of that information available right then and there, and you're taking care of this person, then what would end up happening is the physician or provider would deem the situation necessary to take those life-saving interventions and move forward with that without getting consent. And sometimes there need to be two providers to confirm that and to sign off on that independently. So yeah, in the event of life-saving interventions are necessary, then the actual consent in the way that we're used to doing it on a routine basis often can be waived. So when it comes to the friend, unless they were somehow clearly designated as being their guardian or their power of attorney, then I would agree that would not be the answer to that question. Any other thoughts on that?
No, very good. That's what I had thought when I was going through the rationale, because obviously it didn't say any of that, like, oh, they are their power of attorney, or this has been decided before, whatever. I just wanted to
Right.
ask, because we were on the topic of consent, so thank you.
Absolutely. And that sounds frustrating. Sorry about that. If that was a HESI exam, it might be worthwhile to email them about that. Okay, so let's see what else we want to talk about with blood. Yeah, okay, so the blood unit should be transported from the blood bank for only one person at a time. So, you know, if on the unit there were 2 people that needed blood at the same time, that one person shouldn't, you know, go and get both and bring them back, just one at a time to prevent mixing it up, because obviously you have different blood types, right? And then you're always going to be confirming their identity and the blood compatibility. So kind of the way this process works is that first you're checking the order, making sure that the order is there, you know how many units you're administering, you know if there are any other interventions that need to go along with it, like as I said, you know, giving Benadryl, you may have an order to give, you know, Lasix in between transfusions, things like that. The most critical phase of a transfusion is going to be confirming the compatibility and verifying the client's identity. And you've probably seen this in clinical. There's a universal barcode system used for blood transfusions to confirm all of those things. And there's lots and lots of scanning that has to occur. And I remember being really frustrated with that, because I'm like, I don't know which one I'm supposed to, you know, scan right now. And it's like, okay, that's not the one. Now let's try this one over here. It's like, it can be a little kind of clunky, but it is really important. And you also you're doing that, plus you're also checking the client's wristband as well. It is a double check process, meaning you have to have another licensed nurse there to witness blood transfusion. Let's see. So yeah, so you're checking the blood types, you're using the scanning system, and then once all of that is done, you're going to administer the blood. So you have to maintain your precautions there. You always want to be wearing gloves and be mindful of the fact that splashing could occur. And so, as your instructors have told you throughout the program, you know, you can decide to use as much PPE as you feel comfortable with. Minimally, you want to be wearing gloves during that procedure, but as I said, splashing can occur. So especially when you're taking the blood bag down. So just keep that in mind. And we talked about the normal saline. And the way that I used to do this is that I would first prime the line with the saline. So it comes like in a Y port. First prime the line with the saline and then prime it with the blood. Because if you do it the other way around, if you prime it with the blood first and then you have to get the other side primed too, you're going to end up losing some of that blood. So you always want to do a prime with the saline first. 18 or 19 gauge IV needle is going to be necessary to achieve the maximum flow rate of the blood products and to prevent damage to the red blood cells. If a smaller gauge needle is used, then what might end up needing to be done is actually diluting the unit of blood, but that would be done at the blood bank. Like if you absolutely had to use a smaller gauge needle, you couldn't get access with one of those larger gauges, that may be an option. And then I told you about the central line. You can administer via a central line as well. And then Y tubing. So I kind of did this earlier. So it's done via Y tubing. And there is a special filter in that Y tubing to trap fibrin clots so that doesn't get administered. I talked about pre-medicating, could be, as I said, with acetaminophen, diphenhydramine. You'll already know if they have a history of adverse reactions because you'll say to them, okay, you know, your doctor's ordered blood transfusion. And, you know, have you had a history of, first, have you ever had a blood transfusion in the past? If so, have you ever had a reaction to it? And so if they say, oh yeah, you know, I had this reaction where like I had an allergic type of reaction to it, you would at that point be calling the person that ordered it, and you would inform them of that, and then you'd have an order probably for the diphenhydramine. If you're giving any of those pre-medications orally, has to be at least 30 minutes before the transfusion is started. If it's intravenously, you can give those right immediately before it's started. And you want to tell them, tell me if you're feeling anything abnormal at all. And you need to tell me right away, because sometimes the adverse reactions, or the, not adverse reactions, but the blood transfusion reactions can present in a way that's kind of vague, and especially initially. So you just want them to tell you right away. And a lot of times what people will say is that just that they feel funny. As I said, you begin the transfusion slowly under very close supervision. If you don't notice a reaction within the first 15 minutes, then the flow rate can be increased to the prescribed rate. A lot of the policies will say that the RN needs to stay at the bedside for the first 15 minutes to monitor for signs of a reaction. If there is an ABO incompatibility or a severe allergic reaction occurs, the reaction is usually evident within the first 50 mLs of the transfusion. And that's something that's you're gonna wanna very carefully document, because then moving forward, you know, in the event that they were to ever need a blood transfusion again in the future, that would need to be documented. And they have ways of kind of tailoring the blood components in the event of ABO incompatibility. And then, so document the client's tolerance to the administration of the blood product. That is built into the system. Usually it will prompt you to document on that, and it'll say, you know, tolerated well, or it'll give you the opportunity to document any reactions. If they do end up having a reaction, there will probably be some things ordered to assess further. But if you suspect a transfusion reaction, the very first thing that you want to do, and this might come up on your NCLEX, is stop the transfusion, change the IV tubing all the way down to the IV site, not up here where the bags are. You want to change it completely all the way down to the IV site. And then you're going to infuse normal saline, keep the line open. Because if you were to just, let's say you were to just run this, like, because you could, it's a Y port, so you could close that, the side with the blood, and then you have saline over here already. So why don't you just open that and run it open? Well, anything that's in that blood tubing, any blood that's in that tubing is going to go in. So you don't want to do that. You want to just totally take it all down, and then normal saline with a new line. So notify healthcare provider, notify the blood bank, and there will be a protocol of here's all that you need to do. And you're not going to want to throw everything away, because you're going to want to return the blood bank and the tubing, or the blood bag and the tubing, back to the blood bank so that they can analyze further. Never want to leave them alone. You want to stay with them, monitor their vital signs, and monitor for any, further signs or symptoms. And then lab samples, you're gonna maybe blood samples, urine sample more than likely, because they're looking for hemoglobin in the urine, which indicates that hemolytic reaction where the red blood cells were hemolyzed, and then that ends up showing up in the urine. So those are some things that you would do with blood transfusion reactions. So I wanted to go over that in a little bit more detail, because there's a lot to blood transfusions, probably more maybe than you realize. And this is a common topic to be tested on NCLEX. All right, next question. Nurse is changing the tapes on a tracheostomy tube that was recently inserted. The client coughs and the tube is dislodged. The nurse would take which initial nursing action? Called healthcare provider to reinsert the tube, use the retention sutures or strings to spread the opening, call respiratory therapy department to reinsert the tube, or cover the trach site with a sterile dressing to prevent infection. All right, so let's take a look. Okay, interesting. So majority of you guys wanted to go with covering the trach site with a sterile dressing to prevent infection. We did have a few wanting to do retention sutures to spread the opening, and then a couple wanting to call respiratory therapy department to reinsert the tube. So let's kind of break this down just a little bit. And it's interesting because nobody wanted to call healthcare provider. That's actually the response that we get most often, or I should say the most frequent incorrect response is that one. So it's interesting that you guys didn't want to go with that, because most of the time you would think, okay, it's dislodged, I need the doctor right away. And so think about, so first of all, let's maybe look at some strategies here. So the word initial, that is a word that you want to pay attention to in this case, because what that is saying is that some or all of the options may be appropriate and necessary at some point, but you need to decide what is the initial, what is the most important given this scenario. And then let's look at the subject. What is the question asking about? So the question is saying that the tube is dislodged, and what is the initial nursing action? Okay, so if it's asking for a nursing action, a lot of times it's not asking you about calling the provider. Most of the time that's not the case. Because it wants to know, the question's trying to determine what you know about your role as a nurse. So keep that in mind as a strategy. And so just in general, when it comes to taking care of somebody with a tracheostomy, there's a lot of considerations that you need to have, because this is an artificial airway, right? And so when we're talking about preventing complications associated with the airway, we have to have a lot of things in place to keep the airway patent in the event that something like this were to happen. So if the tube becomes dislodged, you want to think about, what action do I need to take to keep the airway patent? And so in this case, the answer is definitely going to be option number 2, using the retention sutures or the strings to spread that opening and keep that opening open so that they can continue to breathe. So that's the answer to this question. 1 and 3, both great resources, definitely, important to do. But first thing is making sure the airway is patent. And, with option number 4, you wouldn't want to totally cover the trach site, because then they're going to lose their airway. Remember so they have this artificial airway for a reason, and it's lower down than your upper airway. So it doesn't tell us the reason why this person has a trach, but if they have a trach, then it typically means that there's something that necessitated that with the upper airway that was they were having problems, you know, with the patency of their airway in that upper part. And so this then becomes their airway. And so if you're covering it, and I get the point about preventing infection, that is important. It's really important. And they are at a much higher risk for pneumonia, people with a trach. But if you do that, they're going to lose their airway. Okay, so that's not the answer here. All right, next question. The nurse is caring for a hospitalized client with diagnosis of heart failure who suddenly reports shortness of breath and dyspnea. The nurse would take which immediate action? Call healthcare provider, administer oxygen to the client, prepare to administer furosemide, or elevate the head of the client's bed. Sorry, it takes me a minute to find the questions. Okay, there you go. All right, so a little bit split here. Majority want to go with number 4, elevating the head of the bed, and then others want to administer oxygen. So that's good. I'm actually really glad about this because just kind of like with the previous question, we often see students wanting to go with number 3 because they see the diagnosis of heart failure and they know that furosemide or Lasix is kind of a mainstay treatment in managing heart failure exacerbation. I'll just throw this out and you guys can put it in the chat or on mute, but do you guys remember what is one of the more common or more likely complications of somebody with heart failure exacerbation? Any thoughts? They're in the hospital, they're having acute heart failure exacerbation. What might be one thing that's in the back of your mind that you're monitoring for that could happen? Orthopnea, fluid overload. Good. Yeah. So remember, heart failure exacerbation, that's probably already happening. So what's something that could happen that may not already be happening with heart failure exacerbation, do you guys think? Pulmonary edema, yes, absolutely. When you think about the cardiac circuit and what's going to happen if you have the heart, which is the pump, failing, and then when it backs up, a place that it can back up to initially is the lungs, and then later to the rest of the body, to the periphery. And so one thing that you're monitoring for are pulmonary manifestations. And if you have fluid going into the lungs, you can end up with pulmonary edema. So that's something that you want to monitor for. And so often what will happen with this question is students will think, okay, so they're here for heart failure, they're suddenly short of breath. Well, they must be in pulmonary edema then. While I think that's a really good thing to keep in mind, you also want to be careful with NCLEX questions to not read into it in that way, because with the way that the questions are now, is it will tell you, like it will either tell you explicitly what is going on, or it will give you information that is clearly illustrating that happening. So for example, in this case, they say heart failure, shortness of breath, dyspnea. Okay, that's something we might just expect with heart failure anyhow. But if they were trying to paint the picture of pulmonary edema, they're going to give you more assessment information. They're going to say pink frothy sputum. They're going to say, hypoxia. They're going to maybe give you some chest x-ray results, something like that to say, or to demonstrate to you that that's actually what is happening. So in this case, you would want to be careful not to read into the question, because with pulmonary edema, immediately one thing that you need to do is furosemide, and then they need to have a catheter so that you can monitor that the furosemide is working. Like, that's an immediate right now thing in pulmonary edema. But in heart failure, it may not have to be something that's happening right now. So then to get to the correct answer here, which is option number 4. So you guys did really good with that. Elevating the head of the bed. Elevating the head of the bed is, first of all, a correct action in this case. And position changes are often an initial action that you want to take. So keep that in mind as kind of a tip or as a strategy. When you're answering questions, it's asking for immediate action. If positioning is in your options, as long as it's the correct position, that is usually a good first option to go with. All right, let's move on. We're going to take a break at 9:30, guys, so just hang in there. You're doing really good. Next question. Nurse looks at a hospitalized client's cardiac monitor screen and notes this cardiac rhythm. The nurse prepares for which priority measure? Defibrillation, measurement of vital signs, insertion of an endotracheal tube, or administration of IV fluids. All right, let's see how you guys did. Okay, all right, so 86% want to go with defibrillation. So anybody can jump in. What rhythm is this?
VFib.
Yep, thank you, absolutely. So this is VFib, ventricular fibrillation. And so what happens with this rhythm is you have impulses from multiple irritable foci in the ventricles, and what's happening is the ventricles are just firing in a totally, completely disorganized manner. There is no actual pumping of the heart. And so being that it's so chaotic, often really rapid, like it's fibrillating at a very rapid pace, it's quivering, there's no cardiac output. And so for that reason, they lack a pulse. They don't have pulse. You're not really going to be able to get a blood pressure on them. They're not going to be breathing. You're not going to be able to hear any heart sounds, and they'll be unconscious. So with that, you probably can determine that it's fatal if not successfully terminated within 3 to 5 minutes. So even though it's not a flatline asystole, it's essentially, the same thing, because there is no cardiac output with ventricular fibrillation. And so interventions for this are going to be CPR immediately. You start with those compressions right away. And then just as soon as a defibrillator is there, you're using it, because defibrillation is the treatment for ventricular fibrillation. So you don't want to do, I would have students ask me, well, don't we want to do, 2 full minutes of CPR before we defibrillate? Remember, guys, nursing is not, step by step, although that's the way that you have to learn things initially. It's not that way. So you're doing CPR just until the defibrillator gets there, and then you defibrillate as soon as you have it. And usually 120 to 200 joules if it's a biphasic defibrillator, or 360 joules if it's a monophasic defibrillator. And you need to, before defibrillating, check at least 3 times, you're looking like this, to make sure that nobody's touching the client, nobody's touching the bed. And when that's clear, you proceed with defibrillation. And then after that, you're continuing CPR. As soon as they're defibrillated, you continue CPR for about 2 minutes, and then you reassess the cardiac rhythm to determine if further, if you need to shock again or continue CPR, whatever the case may be. And, you're giving oxygen during this time. And then depending on the way that things go after that, they'll need, antidysrhythmics, and, they'll probably go to the ICU if they weren't already there. So, all right, nice job with that. And when it comes to rhythm strips, so this is a figure type of a question. So it gives you an image and you have to answer the question based off of the image, okay? So when it comes to figure questions and with rhythm strips, you're gonna see, the common dysrhythmias you might see, and then they'll ask you questions about that dysrhythmia. So, ventricular fibrillation in this case. Another one might be ventricular tachycardia, atrial fibrillation. You might see bradycardia, and they might do a normal sinus rhythm too. And one question that I heard about being on the NCLEX was they would give a rhythm strip, and then they would ask about electrolyte abnormalities associated with that rhythm. So I would recommend when you're studying, and you can go in the comp review book that you guys have, the orange book, and it should be, I think, in chapter 69 in complex care, goes over it for you kind of in that way. It'll talk about the different dysrhythmias, and then it'll talk about what are the causes, and it touches on the electrolyte abnormalities that can lead to different dysrhythmias. So just make a note to go to chapter 69 and take a look at that. All right, so with this one, we can't do remotes because it's a select all that apply. So we'll kind of just go through this one together. A nurse reviews the lab results of an adult client and plans to report which abnormal results to the healthcare provider. Select all that apply. I know these are your favorite types of questions. And the way that it does work on NCLEX right now is that you have to get all of the correct options correct, and you cannot select any of the incorrect options. So kind of all or nothing scoring right now currently. And so you want to do lots and lots and lots of practice with select all that apply questions, because they're really hard. Just by virtue of the question type, they're really, really hard questions to get correct. Now, I will say that if it seems like you're getting a lot of select all that apply questions, it could potentially be an indication that you're doing well on the exam. So don't let it kind of scare you. If you're like, oh my gosh, I'm getting so many of these, there's no way I'm going to get them all right. Could be an indication that you're doing very well. And so just take it option by option and don't let that anxiety get the best of you. All right, so select all that applies. So we've got, okay, so what are we doing? So reporting which abnormal results. So that's telling you you're looking for something that is abnormal. So option number 1, blood hematocrit of 45%, serum sodium of 140, serum creatinine of 2, potassium of 4, BUN of 30, and then white blood cell of 6,000. So this just requires you to know your normal labs. For all of these on here, I would recommend that you know the normal ranges for these, which is why we go over it. These are the more common ones that you might encounter on the exam. And in the test plan, it'll tell you also what ones you should know. I think we've talked about that before. And the other thing is that I just want to mention before I forget this, because it's really helpful. So in your Evolve resources with your Orange Comp book, if if you go in there and you're using practice questions, which I know all of you are going to do as you're studying for NCLEX, if you go into the Evolve resources and you're going through questions, on the question screen, you're going to see a tab that says labs. And if you click on that, there's going to be a document that comes up with all the normal ranges for multiple labs. So you can use that as a handout, sort of a study guide. And if you can memorize those ranges, then that's going to be really helpful. For you guys, I don't think, we'll have to ask Linda later. I don't believe you're going to see normal reference ranges on your exam for labs. Moving forward, they are going to start including those in the future. But to be on the safe side, I recommend that you guys know your normal reference ranges, by heart. So, all right, so then looking at this question, so normal hematocrit, this is based off of gender, so, male, female, but if we incorporate both, 37% to 52% is considered normal. So 45%, we're okay with that. Sodium is 135 to 145. So, and then serum creatinine is anywhere from like 0.6 to 1.2. So a creatinine of 2 is elevated. So that's something that we would want to report as being abnormal. Potassium 3.5 to 5 is normal. So a potassium of 4, we're good with that. A BUN 8 to 25 roughly is considered normal. So a BUN of 30 is elevated. We want to report that. White blood cell 4,500 to 11,000 is considered normal. So we're good with 6,000. So it's the BUN and the creatinine that we would want to report in this case. So we've got something going on with the kidneys here. All right, next question here. This presents kind of like a chart format. And this is something that you might see. And on the NCLEX, you'll have to click in and out of tabs. So just make sure that you are reviewing all of the tabs. Just to answer the question that came in the chat, yes, that is the Saunders book, the orange Saunders book that I'm referring to. And on day 3, Linda and I will go through or talk about some of the things that we think that you should do in that book as you're studying for NCLEX, and then also on the Evolve site. So just know that we'll be going through that. It's this book. Let me see if I can show you with my background on. Let's see if I can get it up there, or maybe this one. Okay, so it's this book, and we can kind of show you some of the things that we want you to know about. There's a lot of really helpful things in here, different kind of handouts that you guys can, maybe not handouts, guidelines, I guess, that you can look at. We can talk to you about the way that the chapters are organized, how we would recommend you study for NCLEX. There's our list of the top 100 most prescribed drugs in the United States. So these are drugs that you want to be sure to know about. So different things like that. We can go over those things with you on day 3. We planned to. Okay, so back to this question. Sorry, one more question in the chat. Could you repeat where to find resources with the labs that we should know? And I can actually show you guys that a little bit later, but it is in your Evolve resources for this book, for this orange book. So when you go into Evolve, you'll have access to the resources. I think there's a scratch off code on this front inside cover, which you guys can't see because of my background, but you scratch that code off, you put it in to Evolve. So if you haven't done that, you can still do that. And when you go in and you access the questions, any question, it's there with every single question. There's a tab on the bottom that says labs. Click on that. A handout's going to come up in another screen. You can print it out, you can save it, and it gives you all of the reference ranges for the labs that you really want to know for NCLEX. All right, so let's talk about this question. We have just 13 more minutes and then we'll go on a break. So this question shows, again, a chart. When you see this, because we're in PowerPoint, we can't click in and out of tabs, but on the NCLEX, you'll be able to. So when you see this, make sure you review all the information in every tab. Which lab test would be most important for the nurse to monitor in this case? Sodium, chloride, potassium, or bicarb? Let me pull up the poll here. Okay. All right. Good job, guys. Anybody want to venture to say why? Why for the potassium? Unmute or just throw it in the chat.
Sorry, I'm at the jump, so it's kind of loud.
Yeah, no worries.
Because they're on the furosemide, they're going to be feed extra potassium, and then with digoxin levels, you want to make sure. Is it with the potassium? If the potassium is off, that you have digoxin toxicity.
Excellent. And you know, most of the time, students don't get that part with the digoxin. So with furosemide, with it being a potassium wasting diuretic, that in and of itself, we're already watching the potassium level. But then add to that the fact that they're on digoxin. So hypokalemia, as was mentioned, can potentiate digoxin toxicity. And then of course, hypokalemia itself can lead to dysrhythmias. So it's really important that, you know, especially when they're on this combination, digoxin relies on a consistent potassium level in the blood in order to not accumulate to toxic levels. So yeah, potassium is going to be really important in this case, in particular with this combination of medications. Nice job, you guys. All right, so next question. A nurse is using an otoscope to examine the ears of a client. Which finding indicates that the tympanic membrane is normal? So this is a graphic item option or graphic option item. Okay, there you go. All right, let's see how we did. So the answer here is going to be option number 1. 74% of the group wanted to go with that. So that's good. So you have to remember that with the tympanic membrane normally is shiny, like option number 1 is, translucent, and often with that kind of pearly gray color, which you can see with option number 1. If you see an appearance of like a yellow clump, or, you know, there's kind of this material or this piece of earwax, or ceramin is the other name for it, that this is kind of in the external meatus in option number 2. It's like in the external canal or even on like the actual opening. So that's not the membrane itself. Okay, that's showing you a piece of ceramin, which is partially obstructing your view of the tympanic membrane. And then option number 3, what you have there is actually an excessive amount of ceramin in the external canal, and it appears, you know, really dark, and it is obstructing your view of the tympanic membrane as well. And then option number 4, this is, you're actually seeing a hole or a perforation of the tympanic membrane. So obviously that's not a normal finding. All right, so questions so far on anything that we have gone over? If not, we'll keep moving. We're going to go up until 9:30 and then we'll take a break. But the next portion of the presentation is focusing on delegating, assignments, and prioritizing. And we've talked about this in class. We've talked about how delegation is going to be something that you guys are expected to do more and more of, because we now are using team nursing models in a lot of the facilities here in our state. And this is occurring across the country, you know, as a ramification of the pandemic and the shortage that we have. So this is something that not only is it going to be important for you to review and focus on as you're studying for NCLEX, but also for your practice, you will use these principles. So what is this? This is a process of transferring a selected nursing task in a situation to an individual who is competent to perform that specific task. So as you can notice that this is very task oriented. So if you can keep that in mind, that when you're delegating, you're transferring a task, keep that in mind. That will help you to answer questions as opposed to asking somebody to use their judgment in a situation. Okay, so, and then there's also this thing of assignment making, right? So in team nursing as the RN, you will be responsible for determining what the assignments are going to be and who's going to do what within that team. Always wanting to keep in mind client safety, figuring out who it is that you're assigning to. It could be assistive personnel such as a CNA, LPN, and then yourself as the RN and what you're responsible for. We talked about this already in class, matching the task to the delegate. And kind of a general principle is that the non-invasive sort of tasks can be assigned to the assistive personnel. Keep in mind, NCLEX is a national exam, and so you have to just interpret your experiences with caution, in that if there was a specific policy or guideline in one of the facilities that you worked in, that's helpful experience, but interpret it with caution and know that that may not be how it's done nationally. And so NCLEX is only going to ask you questions that are on that level, kind of on a national level. And then provide directions that are clear, concise, accurate, and complete. You want to validate the person's understanding of the directions, communicate a feeling of confidence, and provide feedback promptly after the task is performed. And you need to ask them to come and report back to you once it is completed, and you can ask further questions at that time if you feel that you need to. Maintain continuity of care as much as possible when assigning client care. So those are just general guidelines, and that should be helpful to you when it comes to delegating and prioritizing. In your Evolve resources, there are practice questions that are geared towards delegation and assignment making. So I would recommend that you go in there and practice some of those delegation questions, and that will help you. There is also, let me see, a chapter on this, or a portion of a chapter on this that you can take a look at. It's chapter 7, starts on page 73 of your orange comp book. There's some more information on delegation. And for all of the chapters in the comp book, we have end of chapter practice questions too. So, and maybe I'll use this last 4 minutes just talking a little bit about the book. I think this might be helpful to you guys to know this, you know, now as we're going through the review, because some of your presenters, as I have been, will say, you know, you can read more about that here, or go to this chapter, or go to the Evolve resources. So if you have the book and you look at the book, I'll just kind of go through what the general contents are. So in the first unit, we have information just about NCLEX in general, what the exam is, what to expect on the exam. Those are details that Linda and I will also go over with you on day 3. Chapter 2 talks about how to be successful, how to manage test-taking anxiety, how to cultivate successful and helpful study strategies. Chapter 3 is an account from a recent graduate that talks about their experience with the NCLEX exam. Chapter 4 has test-taking strategies. And then moving on to Unit 2, this is your professional standards in nursing. So you've got your special populations chapter, ethical legal, and the prioritizing, where leadership delegation. You are likely to get a few questions in that area on the exam, because this content is actually found in one of the bigger subcategories of the plan. So I would recommend definitely not ignoring that area for sure. And then we've got foundations of care. I would say that's lower on your priority list. But maybe chapters like fluid electrolyte, acid-base balance, maybe that would be helpful for you to go through. But I would have that be a little bit lower on your priority list. I would say same with growth and development. It might be good to review it, but lower on the priority list, because that will make up a small portion of the test plan. Same with maternity, same with peds. Again, lower on the priority list. Then when you get to Unit 7, this is where we have all the adult, and you can see they're broken down by body system in individual units. This is the majority. This is why there's so much content in these areas. This is where you want to focus, is Units 7 through 7 through 17. And then also you're going to want to look at chapter 69, unit 19, which is your complex care. And then there is mental health. I would say to go through that too, but again, not as high of a priority as your adult health. It's going to be all of these adult health chapters in green. That is going to be really, really important. And we use an outline format, so the chapters aren't too long. We really tried to cut out everything that, we don't think that you would need for the exam. And there's a body system chapter, then followed by a medications chapter, and that's how the book works. So that's really good starting point. If you haven't already gone through the book, go through the book, do the practice questions in the book, and then you also have questions on Evolve. So we're at 9:30. Are there any questions that I can answer right now? And if not, let's go ahead and take a 15-minute break. You can think of your questions on the break and you can ask them at that time too. So go ahead and feel free to shut cameras off, mute, and then we'll come back at 9:45. Devin, I don't know, do we want to pause the recording, do you think?
I can absolutely.
All right, everybody, go ahead and get started. Devin, are you able to restart the recording for us?
The recording has been resumed.
Thank you. Okay. Okay, sorry, I've got my agenda up here on my other computer just so I can make sure that we stay on schedule. Excellent. Okay, so next topic is going to be on prioritizing. Prioritizing is something that you are going to have to be able to do on NCLEX and in your practice too. So what is prioritizing? It's deciding which needs or problems require immediate action and which ones could be delayed until a later time because they're not urgent. Most questions on the NCLEX are going to require prioritizing. And priorities are classified. They can be classified in a certain way. So they can be classified as high, intermediate, or low. Client needs that are life-threatening, or if they're left untreated could result in harm are considered high priorities, whereas non-emergency and non-life-threatening client needs are considered to be intermediate priorities. And then client needs that are not directly related to their illness or their prognosis or whatever the concern is in that moment, those can be considered to be low priorities. So what guidelines can you use when you're prioritizing? So there's a number of principles, models, or theories that you can use to guide your priority setting. One example of that is Maslow's hierarchy of needs theory, which identifies levels of priority. And the first level is physiological needs. The second is safety. The third is love and belonging, then followed by self-esteem and self-actualization. When you guys took your psychology courses as your prereq to the program, or as a prereq to this program, you likely heard of this theory. So you can use Maslow's hierarchy of needs theory as a test taking strategy, and I would recommend that you do that. And we talked about that when you guys were in level 1. Then of course ABCs, airway, breathing, circulation, client needs relating to maintaining a patent airway is always a priority, which is what we saw with the question about the trach. Nursing process, although there's a lot of discussion now about nursing process and whether it really truly depicts our practice as nurses, it is still a helpful strategy for NCLEX, because on the NCLEX, you will have options that are written in such a way that depict performing an assessment versus taking an intervention or performing an intervention. And if the question is not describing an emergency situation, then most of the time it makes sense to gather further assessment data. And so with assessment being the first step in the nursing process, it is a good strategy that you can use. Disaster questions, you will probably get at least one disaster question on the exam. And so you want to know how to navigate those questions. So, for example, if you are at a disaster site, this is usually the scenario that would be presented on the exam. You've got somebody who is actively bleeding from an open wound. You have somebody who has some, visible abrasions on their arm, and, they're leaning against the tree, let's say. And then you have somebody else who has what seems to be an apparent fracture of the arm. And then there's one other person that you see that you can tell they have a very severe head injury. And, who would you take care of first? So that's like a common scenario that you might encounter on the NCLEX. And so you want to think about, from the perspective of first what we said about high, intermediate, low priority. So if we were to go back to this slide and think about life-threatening, if left untreated could result in harm. So who in that scenario has, life-threatening issues? So the person that's actively bleeding, right? Non-emergency, non-life-threatening would likely be that person who, has the abrasions on the arm, they're leaning against the tree. And then I would say too, the fractured arm is non-life-threatening in that moment. The severe head injury, in that case, you would take a quick look at them and see, but if it is at a point where your interventions may be, futile or may not help, then they become a lower priority when you talk about somebody who is actively bleeding. So you'll probably get a question like that. So just be aware of that. Other kinds of questions that you might get when it comes to disaster is who, you anticipate an influx of patients coming into the emergency department, and we need to create space. We need to have open rooms and open beds for the people that are going to be coming in. Who can safely be discharged home? And then it's going to give, examples of patients that, can they resume their care at home safely? So, so if you go into those evolved questions and you go to the prioritizing section, you'll find questions like that you can practice. All right, so any questions that you guys thought of while you were on the break? I'll pause for just a second to see if you have any questions about any of that before we move on. We're going to do a few assignment and prioritizing types of questions, and then we're going to get into pharmacology after that. All right, so first question. RN is planning the client assignments for the day. Which is the most appropriate assignment for the assistive personnel? Would it be a client requiring colostomy irrigation, client receiving continuous tube feedings, a client who needs 24-hour urine, or a client with difficulty swallowing foods and fluids? I'll just find this question. Okay, there we go. All right, so looks like majority wanted to go with option number 3, client who requires urine collection, 24-hour urine collection. So if you don't mind sharing what your thought process is behind that, that would be great. You could type into the chat, you can unmute. Any thoughts? What were you thinking when, so we've got an assistive personnel, urine collection, 24-hour urine collection is what you wanted to go with. So we talked about some kind of general guidelines for assignment making, right? So assistive personnel, this is like a nurse's aide, a CNA, and a really good kind of guideline to use when it comes to assignment making is thinking about non-invasive tasks for assistive personnel. So the 24-hour urine, that meets that criteria. Whereas colostomy irrigation and tube feedings, what do you guys think about that? Do you think that you need to be licensed in order to do those things? Yes or no? Any thoughts? Maybe not sure. So for colostomy irrigation and for tube feedings, it would depend on the state and their Nurse Practice Act, right? We talked about that in class, but from the perspective of NCLEX, when it comes to scope of practice, you want to think about what would be the more conservative approach, and because that's the way that NCLEX is going to go about it. And so you would want to say to yourself, in this case, for options number 1 and 2, that those probably would require a licensed personnel in order to do those. And then what about option number 4? Because a lot of times, and I see a couple of you did pick that one as being an appropriate assignment to delegate to assistive personnel. If you've got somebody with difficulty swallowing food and fluids, what you want to think to yourself in that case is that that person probably needs further assessment and further evaluation. And so if there's ever a situation that's being depicted in that way, then you want to think about a higher, somebody who's licensed, probably in this case, a registered nurse, because the RN is the one who would be performing assessments and then directing care further from that point. And then, once we understand what's going on with that difficulty with swallowing, and we have the necessary interventions in place, such as dietary modifications, thickened liquids, different textures of the food, things like that, that would be directed by, further diagnostic testing, probably doing fluoroscopy, potentially, for sure doing speech therapy consultation, evaluation, and determining what needs to be done for them to safely swallow food and fluids. Then at that point, once we know that, then the assistive personnel can help at that point. But, just looking at that initially, it doesn't seem like it's that big of a deal. But remember, when it comes to swallowing, that there are potential complications that can be really devastating if they were to aspirate. And so if this is something that's being noticed, then the RN definitely needs to get in there to assess further and see what other workup needs to be done. And I will say too, with somebody who's having difficulty swallowing, I mean, even the RN and what they can assess is pretty limited, because you really need direct visualization of the swallowing process to know what the limitations are, and then further to know what the interventions need to be. I was working with a speech therapist one time, and they said like the bedside swallow screens that we do are helpful, but they shouldn't be used to direct what needs to happen, because it's like trying to figure out what's wrong, with somebody's knee without doing an x-ray, and you don't know what you need to do because you don't know what the actual problem is. And swallowing is such an intricate process that you wouldn't want to take that on yourself anyhow. So you can see how important option number 4 is, to have an RN be looking at that. A question I got: would an LPN be able to take care of the patient who has difficulty swallowing, or is the RN still needed for further assessment in this situation? That is a fantastic question, and I'm so glad that came up, because when it comes to RN and LPN scope of practice, one of the main differentiators is, and this is something that NCLEX actually does specify, is that in general, the RN is responsible for assessment. And so when we say assessment, we mean gathering information and then interpreting it, okay? The LPN is responsible for data collection, gathering information, and reporting it to the RN for the RN to then interpret. So when we talk about the team nursing model that you guys are going to be a part of when you graduate, that's one way that you're going to see things done, is the LPN is going to be so helpful to you and important, but ultimately you're responsible for whatever it is that they do. So if they irrigate that colostomy and they report findings back to you, they report the data that they've collected about the appearance of the stoma, the effluent, the surrounding skin. They report all of that to you. It's up to you then to interpret that and to say, okay, do I suspect any complications here? So that's a really, really great question. And that's the way that NCLEX is going to approach that. Okay, moving on. All right, so this is one of our select all that applies, so we won't use the polling for this. Nurse is planning client and unit activities for the day. Which activities would the nurse delegate to the assistive personnel? Select all that apply. So let's kind of just go yes or no, and I'll just talk through it for each of these options. And this is how I would answer this question myself for a select all that apply. I would kind of take one option in isolation at a time. So option number one, so we're talking about assistive personnel. Deliver fresh water to clients. I would say yes, that sounds reasonable to me. I'm going to check that one off. Empty urine out of Foley bags. Yeah, you know, that's a task that could be delegated. Take temperatures, pulses, respirations, and blood pressures. Are assistive personnel qualified to do that? To take the temperatures, to take the pulse? Yes, I'm going to check that one off. They're qualified to do that. Doesn't say anything about interpreting it. If it did, then it would be you'd answer that in a different way. Count the substance control medications in a narcotic opioid medication supply. No, you have to be licensed in order to do that. So you can't delegate that to an assistive personnel. Check the crash cart or the CPR cart for necessary supplies using a checklist. You know, sometimes students do want to pick that because that is, you know, that's a task, but really a licensed personnel, and you guys are probably seeing your charge nurses responsible for this. Licensed personnel should be checking that because remember in the crash cart, there are going to be medications and things like that that require kind of that higher level to be able to determine and for safety reasons. And then check all IV solution bags on clients receiving IV therapy for the remaining amounts of solution in the bags. So again, because that has to do with a task that requires, so really monitoring of a treatment is what that is, right? That requires a license in order to do that. So that's not something we would ask them to do. So it's 1, 2, and 3. All right. Nurse is planning client assignments, has an LPN and assistive personnel on the nursing team. Which client would the nurse most appropriately assign to the LPN? A client who requires feeding, a client who requires frequent ambulation, an older client requiring assistance with a bed bath, or a client requiring frequent wound irrigations and dressing changes. All right, so 83%, we're going with option number 4. Client who requires frequent wound irrigations and dressing changes. So if we think about the difference between option number 4 and options 1, 2, and 3, what you'll notice, I think, is that there's some kind of data collection that needs to occur if we're doing a wound irrigation and a dressing change. I mean, at any opportunity, you could be assessing with any of these activities, right? Like you can assess while somebody is you're doing feedings. You can assess while somebody's ambulating. You can surely assess during a bed bath. However, for wound irrigation and a dressing change, you for sure need to be assessing those things and documenting those things so that further treatment can be directed, right? So, and in addition to that, those are activities that do require licensure as a nurse, whereas feeding, ambulation, bed bath do not. So you guys did good with that. Nice job. All right, so next question. Nurse has received the assignment for the day shift after making initial rounds and checking all of the assigned clients. Which client would the nurse plan to care for first? A client who is ambulatory, a client scheduled for physical therapy at 1 p.m., a client with a fever who's diaphoretic and restless, or a post-op client who has just received pain medication. Okay, good. So 93% wanted to go with option number 3, which is the correct answer here. So who should they plan to care for first, right? So which room are you going to walk into first after you get report? And the nurse says to you, okay, yeah, this client, they're up and walking. This person, they've got PT at 1 o'clock later on today. This person, they had a fever. I noticed that they were a little diaphoretic and they're restless. And I just gave them, their morphine just a minute ago, right before you came on. So kind of picture that and visualize that. And then think about what, if any, follow-up assessments need to occur in each of those situations. So for somebody who is ambulatory, that's like, okay, that's good. There isn't anything about that should make you say like, okay, I need to check on that right away. And then option number 2 is really kind of a matter of routine too. So really nothing pressing there. And then, 3 and 4, so students, they can get it down to 3 and 4 typically. And this sometimes is where they struggle because they're like, okay, we've got somebody who's post-op. They needed pain medication. I really should check on them. I want to make sure they're okay. And the reason why that's not a higher priority over somebody who had a fever, and in addition to that, who's diaphoretic and restless, is because they're post-op, you have to remember that we're going to expect some abnormality in terms of their pain. Well, abnormality, like pain is actually not so abnormal. Technically it's abnormal, but it's expected, right? In somebody who's post-op. And so that plus the fact that they just got their pain meds should say to you that, a little more time could go by so that you can go in, reassess, see how their pain medication is working. And you need a little time for that medicine to work in order to have a good assessment of that. Typically, 15 to 30 minutes or an hour, up to an hour, depending on if it was oral or IV. And then, so somebody who has a fever, so we're already concerned about an immune response, potentially an infection, right? But then you add to that they're diaphoretic and they're restless. These are signs of, okay, something bigger could be going on and you need to check on that right away. They could be deteriorating, it doesn't give us a whole ton of information of, risk factors or anything like that would make you think like, okay, they could be at risk for XYZ. However, that diaphoresis and that restlessness is definitely concerning regardless of the background. So that tells you that something needs to be addressed right away. Nice work on that one. Next question. Nurse stops at the scene of an automobile accident to assist victims. The nurse notes that a client has sustained a traumatic open pneumothorax. The nurse would implement which immediate action to assist? Would they cover the chest wound, instruct the victim to exhale, assist the victim to an upright position, or instruct them to lie still and take slow and shallow breaths? All right, so immediate action. So what that's saying is that some or all of these options are going to be good, but you have to decide on the one that you need to do right now, initially first, immediate. So you guys have here that you want to cover the chest wound. So 84% of you want to go with covering the chest wound. So that's good. That's good. That's the answer to this question. So you've got an traumatic open pneumothorax. That's going to be your first immediate action that you want to do. And then, so instructing the victim to exhale. Rather than that, you would instruct them to inhale and strain against a closed glottis, because that helps to re-expand the lung and to eject air from the thorax, which is what a pneumothorax is that you have air in a space where it should not be. So you would have them inhale and strain against a closed glottis. So they inhale like that versus exhaling. So that's why option 2 is incorrect. And this helps to get the air out of the space that it should not be in. And then as far as assisting them to an upright position, you don't want to do that. Does anybody know why you wouldn't want to assist them to an upright position in this scenario? Any thoughts? So you have somebody who automobile accident, they have an obvious injury here, right? Would we want to move them? We would not want to move them until, I think I heard somebody unmute. Please feel free to jump in if you would like.
Sorry, I was just reading into the question too much. I was just thinking I would be worried about a possible spine injury due to the accident, so I wouldn't want to move them just in case that could make things worse.
Yeah, no, and Nick, you're not reading into it. That's good. That's exactly right. So you've got the accident. You need to make sure that it doesn't say that their C-spine has been cleared. So that would be something that before they're moved, you don't want to do that. So nice, good job. And then instructing them to lie still. Yes, we would want to do that. But there's also this other part of this option, which says to take slow and shallow breaths. That's not something that we would necessarily advise them to do in this case. And we want them to take nice inhale, nice deep inhale kind of a breath. So when you have a 2-part option, make sure that both parts of the option are correct. Because even though lying still is correct, the other part of that option is not. So just be really careful. And that's why it's so important to make sure that you're reading everything, right? All right, next question. Post-op client suddenly develops chest pain and is experiencing dyspnea and tachypnea. The nurse suspects that the client has pulmonary embolism and immediately plans to take which action? So it's already giving us the suspected complication in this case, and it's giving us some assessment data: chest pain, dyspnea, tachypnea. So which action are we going to take immediately? Are we going to administer nasal oxygen, place the client on a cardiac monitor, prepare the client for a perfusion scan, or ensure that the IV line is patent? Sorry, give me just a second here. I have to like count these out. Okay, found it. All right, so answer is option number 1, and 68% wanted to go with option number 1. Some of you guys, cardiac monitor, perfusion scan, patent IV line, these things all do sound really important, don't they? In a case like this, and they are all important because we know for pulmonary embolism, first and foremost, we know that they're going to have problems oxygenating as a result of the embolism blocking that exchange in the lung. Okay, so that is the biggest rationale why administering nasal oxygen is going to be the answer to this question, is that they need supplemental oxygen to ensure adequate oxygenation. It's going to be important that they're on a cardiac monitor too, because this is something that we need to make sure that there isn't any effect of the pulmonary embolism on the heart, because we know, again, it's a connected circuit, and so that's something that could potentially occur, and we would just want to monitor for it. And in addition to that, somebody who has a pulmonary embolism probably also has risk factors for dysrhythmias, right? So it's important, but it isn't the priority, because we know that the actual problem here that is already currently existing is problems with oxygenation from the PE. The perfusion scan. So yeah, this is going to confirm. So we say here that the nurse suspects a PE based off of their assessment, the fact that they've had surgery, they're post-op, they're at risk. And so what are we going to do to confirm that? The perfusion scan is something that we need to do to confirm that. So good option, but in the context of oxygen, it's not the priority. And really kind of same goes for IV line. And, a lot of these things, you could visualize it in real life. They'd probably all be happening at the same time. But with NCLEX trying to determine your ability to prioritize and what needs to happen first, you will encounter questions similar to this. So option number 1 is your answer here. Next question. Nurse on the day shift is assigned to care for 4 clients. Following report from the night shift, which client would the nurse assess first? So here's another one of those questions that similar to what we looked at earlier, and you will get these questions. Client scheduled for cardiac cath at 10 o'clock. Client scheduled to have an ECG at 9 o'clock. Client with pulmonary edema who was treated with furosemide at 5 o'clock. Or client newly diagnosed with diabetes who's scheduled to discharge home. So think about that while I find this question here. All right. I think I saw some people maybe changing their answers. So majority of you guys wanted to go with option number 3 as the answer here, which is the answer. So pulmonary edema, they had to be given furosemide at 5 o'clock. Okay. So I mean, think about pulmonary edema and what that is, what's happening, and what the potential risk is if that's not adequately treated. That could very much be a life-threatening condition. Okay, so we look at option 3 and we already determine that a potentially life-threatening condition is occurring there. Now, looking at option number 4, because a few of you chose that, and that's not uncommon when we do this review. A lot of people do want to go with that because when you see newly diagnosed with diabetes, you're like, oof, they need to be monitored really closely, right? Which is not incorrect. However, they're scheduled for discharge to home. So that should say that they're stable, right? They've been stabilized, and surely we need to go in, we need to do education, we need to make sure that they're ready, they've got everything that they need. But that's not going to be the one that we go to first. And then cardiac cath, there were 5 of you guys who wanted to go with that, which, so I mean, I think I do understand why, because you see cardiac cath and you probably are thinking, well, there's something going on here that is necessitating a cardiac cath, and that's true, that's true, but there's definitely varying degrees of urgency for that procedure. Those even can be done on a routine basis, and then an emergency basis. So, but if they're scheduled for it, right, they're scheduled for it at 10 o'clock, that tells you that, they're stable, right? They're stable. And then I would say the same for option number 2 with the ECG. It's scheduled, it's a test that they want to do, but since it's scheduled, that should say to you that there aren't any, active signs or symptoms that this is something we need to know right now, what the electrical activity of their heart is looking like. And so then with that, I would go with option number 3. These prioritizing questions, they can definitely be tricky. You guys are doing really good though. Next question. Nurse is performing nasopharyngeal suctioning on a client and suddenly notes the presence of bloody secretions. The nurse would take which action first? Continue suctioning to remove the blood, check the amount of suction pressure being applied, encourage the client to cough out the bloody secretions, or remove the suction catheter from the nose and begin vigorous suctioning through the mouth. Sorry guys, it's going to take me a second. All right, so majority wanted to go with option number 2, check the amount of suction pressure being applied. Yes, that's going to be the answer to this question. So if you visualize the procedure, right, nasopharyngeal suctioning, and you start to see, so it says suddenly notes the presence of bloody secretion. So that is a change. Anytime you're seeing a change, you want to kind of notice that and have a heightened awareness to that and think, okay, what happened here? And so you wouldn't continue to suction to remove the blood because that wasn't something that should be happening because it's a change, it's different. So you wouldn't continue suctioning because you can actually cause further damage. And it could be, and probably is, the suction procedure itself that's causing that. So then option 2, check the amount of suction pressure being applied. Yes, that's going to be helpful and important to do to make sure that it's not the suction catheter, adhering to the walls that's then causing an injury and bleeding to result. And then as for encouraging the client to cough out the bloody secretions, well, I mean, if you think about that, if we're suctioning, then probably their cough is ineffective. So, so you can do that, but may not be so helpful. And then removing the suction catheter from the nose and then begin vigorous suctioning through the mouth. So we do nasopharyngeal suctioning because it helps to, in a way, bypass that kind of, gag reflex. It still does occur, but if you go up the nose and then down, like through the back of the throat, it makes it much more tolerable versus going in through the mouth. And because it's like the posterior 1/3 of the tongue is what initiates the gag reflex. And so there's not really a reason to do that. And then just a question here about what would you do after the fact in the case where you suspected that there was too much suctioning occurring, which then resulted in the bleeding? Would you call healthcare provider? My next step, I think, would be to call respiratory therapy because they're really the specialists that can help. First of all, help if it's probably a technique problem that's causing this, something to do with the way that the suctioning is being done or the amount of suction being applied or whatever it is. So get them there first to further assess the situation, determine, is there something that we need to be concerned about, where we would maybe need to call the doctor and see if we need to look at this more, or is this something that it's going to just probably go away on its own and we're going to fix the technique, lower the amount of suction, whatever it is. So that would be the first step. And then depending on that, potentially would need to call the healthcare provider as well. Excellent. Okay, so next thing is, so we talked a little bit about this, but we can just talk just briefly a bit more about your priority in terms of victims in a disaster situation. Often there is a coding system that we use, and the first priority victims are going to be the ones that are coded as most urgent, usually that they're given like a red tag or something to depict that. And those are the ones that have life-threatening injuries and are experiencing hypoxia or near hypoxia. So examples of this include chest wounds, internal hemorrhage, head injuries producing increased loss of consciousness, partial or full thickness burns over 20% of the body surface, and chest pain. Okay, so those are going to be your first priority victims. Second priority victims, these are urgent, coded yellow, typically, have injuries with systemic effects, but are not yet hypoxic or in shock and can withstand a 2-hour wait without an immediate risk. So an example would be a victim with multiple fractures. So that we do definitely need to take care of that, but could they wait a couple of hours? Probably yes, right? And then third priority victims, coded green, have minimal injuries unaccompanied by systemic complications and can wait for more than 2 hours for treatment without risk. So like, for example, a leg sprain. And then dying or dead victims have catastrophic injuries and would not survive under the best of circumstances. And those are typically coded black. And so they are lower priority, unfortunately. All right, so to call the doctor or to not call the doctor. So this is, this is something that we get a question about a lot. And remember that NCLEX is a nursing exam. And so you're more likely to be asked about something that you, as the nurse, can handle. That's not to say that collaborating and calling the provider is not a very important part of our practice, because it is. But the point is that you're more likely to get questions about something that has to do specifically with your scope of practice and what activities you would be doing as the nurse. So keep that in mind, is that those questions are few and far between. And because of the fact that the questions are often prioritizing in nature, and they're asking, what would you do first? A lot of times you're not calling first. You're doing other things first. You're collecting more information first. You are looking at what existing options you have in terms of orders first. You're trying that first. And then if you still need something at that point, that's when you're calling. If we're talking about an emergency situation, however, even then you're probably taking an action to address that situation, but then very soon after you would be calling them to inform them and get further guidance. But again, it's just not that often that that's going to be the answer to the question, because they're not testing you on, your ability to call or not call. It's really like how you safely perform within the role of the nurse. So keep that in mind. So with that, let's take a look at this question. The nurse is caring for a client who just returned from recovery room following tonsillectomy and adenoidectomy. Client is restless, pulse rate is elevated. The nurse prepares to continue assessing, but the client begins to vomit large amounts of bright red blood. What's the immediate nursing action? Contact the surgeon, continue with the assessment, give the client ice chips to suck on, or obtain a flashlight, gauze, and a curved hemostat. Sorry, guys, almost there. Found it. We won't have this problem in the future, I don't think. I think it's because the title is so long, so it doesn't show me the whole thing. Maybe if I expand this, I'll try that. This might help. All right. Good job, you guys. So yeah, this is a situation where we got to call, right? We need to call. So again, few and far between usually, but there are going to be certain situations where we need to contact the surgeon, the healthcare provider right away. So in this situation, tonsillectomy, adenoidectomy, I mean, think of where that is, right? That could very easily potentially obstruct the airway. And the fact that they're restless, their pulse is elevated, now they're vomiting large amounts of bright red bleeding. You should try to interpret that and say to yourself, what needs to happen in this case to make sure that we're going to have a good outcome here? And So continuing with the assessment, well, you've got it. I think you have enough. This is a good strategy. Do you have enough information here to make a decision about the next steps in care, or do you need more information? In this case, you have enough information. You don't need to continue the assessment. You've got enough. You need to know what you should be doing next. In this case, you definitely want to keep them NPO, no ice chips, nothing like that. For somebody who has had a surgery like this, flashlight, gauze, curved hemostat, it's like trying to think what you would be doing with that. I'm picturing this, and I'm picturing, somebody trying to maybe put pressure on the site of bleeding or whatever with the flashlight in the throat. You don't want to do that. That could cause further problems and could potentiate airway obstruction. So that then leaves you with option number 1. Any questions about anything that we have talked about? That wraps up our delegation and prioritizing section, and we're going to move into the pharmacology. Any questions about anything so far? Just going to check our agenda. So we have this section we have planned until 11:30, so about another hour. Don't think it's going to take that long though. Let me see. No, actually not at all. So what we can do, we'll finish this up, and then we've got maternity after lunch from 12:30 to 2. So probably what we'll end up doing is, I think we're going to end up having a little bit of a longer lunch, which I'm sure you guys won't mind that. But let's finish up this section, and then we will go from there. Okay, so strategies for pharmacology questions. So pharmacology, there's no way around this, you guys. There's no way around pharmacology. It's one of the areas that we hear that students have a lot of anxiety about and tend to struggle with how to not only answer pharmacology questions, but how to study. How do we even approach studying pharm? So let's talk about a few ways you can do that. So first of all, learning medications by classification. If you can learn the meds by classification, that tremendously cuts down on the number of medications that you need to know, because they're grouped in these classifications. They have a similar mechanism of action, and therefore will have similar side effects, adverse effects, and nursing implications. So think about that, right? So if you can learn by classification, that's going to be very, very, very helpful to you in your studying. One thing that I want to mention now is with your Evolve resources associated with the Orange Saunders book, you can go into the Evolve resources, which has your practice questions, right? And you can filter by medication classification. So I just encourage you to go in there, play around. We'll demonstrate some of this for you. I think on day 3 is when we are planning to do that. But you can go in, you can click study mode, and then you go into the content area, pharmacology, and then there's drop downs, and you can go first by body system, so cardiovascular, respiratory, and so on. And then you click another drop down, and it'll give you your beta blockers, your ACE inhibitors, go by classification. So you can study in that way. And that, just by doing that, you're going to help, or you're going to start to learn, which to some extent you have already done this, of course, but you'll start to recognize, like if you're studying your beta blockers and you go in and you're answering questions about beta blockers, you're going to see names of beta blockers, right? So you're going to then start to recognize which medications belong to which class by studying in that way. So I highly, highly recommend that you do that. And then in your book too. So let's say we were to look at endocrine problems. So unit 9 starts on page 605 is endocrine medications. It'll break it down also. That chapter breaks it down by med classification and kind of the major categories. And then there's boxes in these chapters that will tell you what the more common names are. Okay, so like you've got your corticosteroids, glucocorticoids, your androgens, your estrogens, progestins, all the information that you need about insulin, other hypoglycemic medications to treat diabetes, So it's broken down in that way. There's multiple boxes to show you those common names. It's really, really, really helpful. So I highly recommend doing that. Maybe I could even picture myself going through each of these chapters and kind of compiling like a study guide or something that of all these boxes that has all these names of the medications within each class and having that be kind of like a cheat sheet. I could see myself doing that. So that way, if you get a question about, and they're going to say medication names, they're going to say medication names. So you want to be able to, as much as possible, recognize that name. But then from there, you're going to have studied that class that it belongs to. So again, you'll know what the therapeutic effect is, the mechanism of action. You're going to then know, what parameters need to be monitored, side effects, adverse effects, and nursing implications, patient teaching, all of that stuff. There's a tremendous amount of information to know with pharmacology. There's no way around that, but a way to make it more manageable is to learn by medication classification. And then, if you go on page 1134 of your comp book, it's at the very end, you have United States top 100 prescription medications by generic name. So you can look at this list, go through it and say, I know what that is. I know what that is. I know what that is, because these are the ones that you're more likely to be asked about on the exam because they ask about the more common medications. So we had our consulting pharmacist help us put this list together. And so I think it's a really, really helpful resource for you guys to look at. Questions about any of that? Okay, hearing none, we'll keep going through. So in addition to learning medications by classification, you also want to note the medication name and look for letters that identify a particular medication classification. So, for example, ACE inhibitors end with the letters PRIL or PRIL. So enalapril, for example, captopril, lisinopril. That's one way to identify that those belong to that class. Another example, your antilipemics or your medications to treat high cholesterol. One classification that's really common, very widespread use of this class are your statins, right? Those are your HMG CoA reductase inhibitors is the long name for it, but they're commonly referred to as statins. So like atorvastatin, simvastatin, rosuvastatin, lovastatin. You can identify that suffix and then you can then remember about that classification. Antiviral medications contain VIR in their names like ritonavir, acyclovir, valacyclovir, remdesivir. So those are your antivirals. They often contain VIR. And beta adrenergic blockers end with LOL, like atenolol, metoprolol. And then glucocorticoids or corticosteroids, often referred to interchangeably, often end with the letters SONE, like prednisone. So keep that tip in mind as well. And I was just looking for it here. I think I can't find it in here because I think it's in our strategies book, but we have, I want to say it's in chapter 4 in the test taking strategies chapter. We talk about some of these strategies for answering pharmacology questions, and we give all of these tips in here. Okay, so take a look at chapter 4, starts on page 26, and towards the end we talk about strategies. Here it is on page 35, answering pharmacology questions. You can read through that chapter, that part of that chapter, and it will give you some good ideas, which I'm going to talk about briefly next. So just in general, you want to make sure that you know for each classification, what's the intended effect, what's the side effect, what's the adverse effects. Okay. And you want to learn side effects. In particular, you want to learn side effects, right? Because this is a big patient teaching point at the time that they are prescribed the medication. Here are the side effects. Not that you're getting ready to be an advanced practice nurse, but as an APRN, when I prescribe something, my next thing is, here's some of the side effects for you to expect. And here are some things that can occur, but we want to know about right away if they do, which those are your adverse effects. So patient teaching is huge with pharmacology. You will probably get questions about patient teaching for, new medications or side effects or something like that. Your nursing interventions are going to be tied to some extent to one of these things: the intended effect, side effect, adverse effect, right? Your nursing interventions are going to be to monitor for pain relief after you give a pain medication. Your nursing intervention is going to be to monitor for GI upset for a new medication like metformin, and then to initiate the teaching that says that this is an expected side effect. It might be helpful to take it with a little bit of food. We often see this side effect subside after a couple of weeks. That is so important, because if they don't know that up front, they may just stop taking it, and then that's not going to help them with what it is that they're taking it for, obviously. Adverse effects, again, an opioid medication that's being given to somebody post-op who happens to be opioid naive. We know that an adverse effect is respiratory depression. So what's our associated nursing intervention? We're going to be monitoring their respiratory rate and vital signs very closely, right? So just some examples, but you can often tie these things together. Your nursing interventions are going to in some way be related to one of the effects of the medications. Using medical terminology to break down the medication name into parts, that can be a really helpful thing to do as well. So sometimes, not always, it would be nice if the medications did have those common prefix or suffix across the board, but that is not the case. But if you can break it down into parts and try to identify those, it will help. And then focusing on the diagnosis if it is available to you in the question, because that's going to give you an idea of what the medication is being used for. It's going to tell you what the intended effect is, right? If it's for breast cancer, cyclophosphamide has been prescribed for client with metastatic breast cancer. Well, so that's going to help you to determine the fact that cyclophosphamide is an anti-neoplastic medication, right? So if that's available, just pay very close attention to that. Remember that the question will identify the generic name of the medication, but not the trade name. There are multiple trade names that exist for one generic name. So NCSBN has made the decision to focus only on generic names, okay? Which is helpful, I think, but the downside is that in clinical and in talking with your patients, you guys have probably had to use those trade names or the brand names that are easier to say. So it's hard, but for testing purposes, focus for sure on the generic names. Let's see what else. So for each class, I would do, if you're a list person, I would, make a short list, maybe the top 3 to 5 most common side effects for that drug class, top 3 to 5 most common adverse effects for that drug class. And I think that will help you to learn those things. And then focus on, of course, always what the question's asking or the subject of the question. Determine, is the question asking me about an intended effect, side adverse effect, or even a toxic effect? So think about those things. And it doesn't always use that terminology in the question. You have to kind of read between the lines, so to speak, and determine for yourself which of those is this really trying to get at. And then now medication calculation questions, you might get 1 or 2 of those on the exam. Those are going to be your fill in the blank questions. Remember that a calculator is going to be available for you on the computer. And what you want to do is talk yourself through, make sure that the answer that you've come to, it makes sense. You always want to recheck the calculation before hitting submit. And just try to ask yourself, like, does this seem like a usual dosage for this medication? Like, you're not expected to know normal dosage ranges. But you might be able to pick up on something unusual, like, let's just say, I don't know, 40 mLs of morphine, right? I mean, that seems excessive, doesn't it? So you'd want to pick up on something like that if that is what you came to in your calculation, and say to yourself, let me go back and recheck this. Other kind of points, just general points. And let me make sure I don't have a slide on this. No, I don't. Other general points that you want to remember: they should not take an antacid with a medication, because the antacid can affect or will affect the absorption of the medication, because the antacid is inhibiting, right, the acid in the stomach, which is required for adequate absorption if the medication is taken orally. So no antacids. They say, what is it, an hour before or 2 hours after an antacid. And then enteric coated and sustained release tablets should not be crushed. So if at all possible, right? And if you were to ever find yourself, this is more so for in practice, because on NCLEX, just answer it in the way that you wouldn't do that. But you might have noticed that sometimes in practice, it's like really hard for people who have an NG tube, G tube, J tube, and they're on these medications. You should consult with the pharmacist to see, is there another form? Can we give it liquid? Or is there an alternative that can be prescribed? So that we don't have to crush sustained release or enteric coated tablets. And then capsules really shouldn't be opened either. So kind of same situation with that. The client should never adjust or change a medication dose or abruptly stop taking a medication. So if you have any option that is depicting any of those things, they're not going to be good answers. So avoid those. Client should avoid taking any over-the-counter medications or any other medications like herbal preparations unless they're approved. So, this is something that maybe you have come across in clinical, but I remember as a nurse, like when we were discharging patients, they would ask questions about, well, can I still take my Tylenol, or can I still take my, whatever herbal preparation that they would take? And you can't really just answer that question. You need to check on that, because there are the potential for interactions, and they can even be dangerous interactions. So you would not want to do that. That's really beyond your scope of practice, even though it's over the counter. Okay, so just keep that in mind, and that's how you should answer that, something like that on the NCLEX if it were to come up. No alcohol, no smoking is a good general rule to follow for NCLEX when it comes to medication questions. So if there was an option that says that they would consume a limited amount of alcohol, or that talks about, they're going to cut down on the smoking or something like that, those aren't good answers, because the answers should be nothing, none, which isn't realistic, but that's how you want to answer it on NCLEX. And then, in this day and age, this really shouldn't happen anymore, but if the prescription is difficult to read, it's somehow unclear, or it identifies a medication dose that isn't a normal one, the rules about the nurse being the last line of defense very much apply on the NCLEX exam. So if any of those things are apparent, then the nurse would not administer the medication and would first seek clarification. All right, I don't see any questions or anything, so I'm just going to keep moving on. And we have just a few practice questions to go through on pharmacology. And then what we have is, as we're going through each body system, there's going to be medication questions integrated into those as well. So this isn't going to be the last time that you see pharmacology. This is just kind of your intro to it. And then, when Ms. Trinka comes and does maternity, she's going to have maternity medication questions. And then when we go through all of the other body systems, we're going to have medication questions at that time as well. So let's go through these last few questions here. Client shares with the nurse that he needs dental surgery, but the client's dentist does not feel comfortable doing the surgery because they take clopidogrel every day. Which response would the nurse make to the client? You should probably change dentists. That's a question for the pharmacist. There's no risk to having such a minor surgery while taking clopidogrel. The surgery can be safely done 7 to 10 days after the medication is stopped. Can't believe I'm like just figuring out how to do this now. You guys would be laughing at me right now because I just had to expand the window so I could see the numbers. Oh, sorry about that. All right, so let's look at this a little bit. So 78%, 25 of you guys wanted to go with option number 4, which is the correct answer to this question. The surgery can safely be done 7 to 10 days after the medication is stopped. So let's first look at the medicine here. So clopidogrel. This is classified as an antiplatelet. It works by decreasing platelet aggregation, which means kind of the grouping, right, of platelets together, which could then result in a blood clot. And so as an antiplatelet, it works to decrease that grouping. So then what you should think to yourself is that there's then a risk for bleeding because of that mechanism, because of that intended effect. Platelet aggregation is one of the really important clotting mechanisms. And so if that is inhibited, that risk is certainly there. So this applies to this person on clopidogrel, or, you know, somebody taking an aspirin too, just, you know, as a preventative, which is a very common practice. So there's the risk for bleeding. So that's where our thought process is at this point in time. And so they're going to the dentist, which it does specify that it's a dental surgery in this question, but also know that even for somebody going for a routine cleaning that is on this medication, they need to find out if that medicine should be stopped, because they can still have bleeding even during a routine cleaning. So it may need to be stopped. And so that should be clarified before their dental visits of any kind. So obviously, you know, changing dentists, no, that's not necessary. And pharmacists are very helpful, very, very helpful, but it's still your responsibility and within your scope and your role to answer a question like this. You can consult with the pharmacist if you're unsure or you need more information. They're a fantastic resource, but nurses should also be equipped to answer this question. And we don't know, looking at option number 3, if it's minor, if it's major, and as I said, bleeding would still be a risk even during a routine dental procedure. Nice job. Okay, so next question. The nurse prepares to provide instructions to a client who has received a long-term prescription for prednisone. Which instruction would the nurse include? Take the medication at night to enhance sleep. Medication must be taken with food in order to prevent gastrointestinal upset. Medication should not be stopped abruptly because withdrawal symptoms can occur. Or sore throat and sudden weight gain is normal with this medication, and it does not need to be reported unless it becomes extremely bothersome. All right, let's see how you guys are doing here. Okay, so most of you wanted to go with option number 3. Medication should not be stopped abruptly because withdrawal symptoms can occur. So that is going to be the correct answer to this question. Prednisone is a corticosteroid. It is also a type of anti-inflammatory drug. It is used for a number of conditions, such as rheumatoid arthritis. It can be used for asthma exacerbation. It can be used for allergic reactions that are really severe, COPD exacerbation, multiple uses of this medication. It's a really, really great medication. And it can be taken for long-term conditions, for certain long-term conditions. So, but if it is, because we know that everything has side effects, right? What ends up happening is that in the adrenal glands are the glands that normally produce corticosteroids naturally. So when you have synthetic replacement on a long-term basis, it actually starts shutting down that system. This is similar to long-term use of proton pump inhibitors, which shuts down the proton pump in the stomach. So with abrupt withdrawal, you end up having no corticosteroid production at all, which is essential to life. You need that in order to live. And so this can lead to withdrawal symptoms and possibly adrenal crisis. Okay, so that's an important one to remember. Adrenal crisis can occur as a result of a lack of cortisol. And what they might experience in that case is lightheadedness, dizziness, weakness, sweating, abdominal pain, nausea, vomiting, even loss of consciousness. So it can be really severe and life-threatening. So if somebody is going to be prescribed long-term prescriptions of prednisone, this is a very important teaching point that needs to be brought up at the time that it's prescribed. Nice work. Oh, and I did want to talk briefly about the other options because these are kind of important points for prednisone. So prednisone should be taken in the morning versus at night because it mimics the normal burst of corticosteroid, which occurs upon awakening in the morning. So you want to take it in the morning for that reason versus at night. That's one important thing. And usually, I mean, this medication typically can be taken without regard to food because GI upset is not really a known side effect for this medication in particular. And then for option number 4, sore throat. So one thing that can occur because prednisone can cause a state of immunosuppression. Perhaps you have heard this. It's considered an immunosuppressant medication, especially if taken on a long-term basis. Agranulocytosis is a potential, rare but potential effect of prednisone, which means that your blood cells are not responding in a way that they would or could in order to work in the event of an infection. Sore throat is a sign of a potential infection. And so if somebody has a sore throat and they're on long-term prednisone, we know that they're immunosuppressed. It's something that we would want to look at right away just to make sure that they're not going to get really severely ill from a potential infection and a lack of an immune response to that infection. And sudden weight gain. Sudden weight gain is not normal, right? And really in any circumstance, weight gain over time with prednisone is a known side effect. But for it to be sudden, that's not normal. So both of those things would need to be reported, and that's why that is an incorrect option. Okay, next question. Which adverse effect should the nurse instruct the client prescribed atorvastatin to report immediately to the primary healthcare provider? Tiredness and fatigue, flushing and redness, muscle pain and weakness, or flatulence and constipation? All right, so we are looking like we want to go with muscle pain and weakness for the answer here. So this is good because that is the answer. That's the correct answer to this question. And what this sign symptom is depicting potentially is the adverse effect of rhabdomyolysis, which is a rare complication of statin medications. Rhabdomyolysis is a serious medical condition. It can be fatal or result in permanent disability. It occurs when damaged muscle tissue releases its proteins and electrolytes into the blood. And then what happens is that those substances can damage the heart and the kidneys, which is then what results in that permanent disability or potentially death. Does anybody know what blood test is done to detect rhabdomyolysis? Type it into the chat if you happen to know. Okay, I'm not seeing any, which is fine. Okay, I see myoglobin. Okay. So it's going to be, so that's close. It's going to be your creatinine kinase, your CK level. And if that's elevated, that could indicate rhabdomyolysis. So that would be something that needs to be treated. And usually the way that that is treated is stopping the offending agent, the causative agent, which in this case would be the atorvastatin, and then hydration therapy. So some examples of, like I said, these are the HMG-CoA reductase inhibitors. It include atorvastatin, fluvastatin, lovastatin, pravastatin, rosuvastatin, and simvastatin. One kind of point that I do want to bring up is that, and this is particular to lovastatin within this drug class, it's highly protein bound. So that particular medication in this class should not be administered with anticoagulants, and it should not be administered with a medication called gemfibrozil, okay, because it's highly protein bound, and so they have kind of an interactive effect with one another. So that's particular to lovastatin. And then also for lovastatin, it should be administered with caution to anybody taking immunosuppressive medications. So typically I don't see lovastatin prescribed all that often anymore. And I think due to these potential for interactions. So you'll probably see simvastatin's a really common one. Atorvastatin is a really common one. You'll probably see those more often. Side effects, adverse effects of your statins are going to include nausea, diarrhea or constipation, abdominal pain or cramps, flatulence, dizziness, headache, blurred vision. They can have rash with pruritus. They can also have elevated liver enzymes and the muscle cramps and fatigue, muscle pain, weakness, fatigue. So those are the ones, the elevated liver enzymes, muscle cramps, fatigue. If they came with rash and pruritus too, I would want to check their liver enzymes because that could be a manifestation of something going on with the liver. So people who have liver problems often will not be prescribed a statin. We don't any longer do baseline liver function studies on people because it's been shown to not be necessary because it's just a very small amount of people who really wouldn't meet the criteria, the safety criteria for a statin. So we don't do that anymore. We used to do baseline liver function. Now we just monitor for these adverse effects, and we'll check it if we think something is happening. So the other thing for statins, annual eye exams are important because these medications can actually cause cataract formation. And then if these medications are not helpful or effective in lowering the lipids after 3 months, they should be discontinued. We should try other things at that point. And then a really important teaching point when somebody's being started on a statin is to report any unexplained muscular pain immediately. So if you feel that, notice any weakness, then you need to report immediately so that we can check a CK level, stop the medication, and see if maybe you need to be rehydrated and, you know, check kidney function, liver function. And yeah, so that's the statins. Do you guys have any questions about any of that? It's a pretty decent overview of statins, so you should hopefully be able to answer any questions that come up on NCLEX about those. Okay, so that brings us actually to the end of this section. Let me take a look at our agenda here. Sorry, give me just a second here. So we were planned to go actually till 11:30 for this section, so we're about 10 minutes early, and then we have a Q&A. I don't know if Linda is here because Linda was potentially going to join me for the
I'm here.
Q&A. Awesome.
Yeah.
Well, that's great. Linda, is there anything, and I can stop sharing this so we can see each other. Anything that you want to say or add at this point, since we're just a little bit early, and then we can see what questions they have too.
You've really covered things very well. And, you know, the fact that you brought up the Orange Book, because that's going to be a key thing for them to get ready for the NCLEX. And as you said, we'll talk more about that on Wednesday. One point that I know came up was about labs and whether or not the NCLEX that they're going to be seeing, lucky them, not NGN. And as far as the lab values, it's hard to know what they're doing as far as showing you normals, a normal reference range, and identifying whether it's high or low. We're not positive they're doing that yet on the exam. So in light of that, we highly recommend that you know some of those lab values, the most common ones. Now, Angela may have brought up the test plan to you, the NCLEX test plan, and going to the NCSBN site and downloading that test plan for yourselves. And in that test plan, it gives you all of the activities. It actually tells you what they're going to ask you on NCLEX. So what better study guide? And in that test plan there, I think it's under physiological integrity area, it lists the actual lab values that they're going to ask you about. So if you could at least know those, what the norms are, and what it means if they're high or they're low, you'll be all set with that. Okay, so I just wanted to make that point about the test plan and the lab values. And again, we're not quite sure if they're giving you the norms, but if you know those, you'll be fine for the exam. And the other point was about cardiac, the dysrhythmias and the electrolyte imbalances that occur with them. And you'll probably be asked about that. And Angela mentioned that that was in your, I think it's chapter 69 in your book on the complex care chapter. And I think the fluid and electrolyte chapter in that Orange Book also tells you what dysrhythmias or what you're going to see occurring with the different electrolyte imbalances. So you want to pay attention to that too.
Thank you,
Okay.
Linda.
What question?
I had a question come through in the chat that says, do you recommend getting a hard copy of the NCLEX book if we have the ebook version? And for me, I think it's a personal thing, and I want to hear what Linda thinks too. But I personally like to have both, only because I like the search function with the ebook if I'm searching for something, but that really might have to do with the fact that I'm writing versus studying. So I think for studying, my preference would be the hard copy. Linda, do you have any recommendations on
No,
that?
I completely agree with you. I like the hard copy. I think it's easier to visualize things when you're looking at some content and it's referring you to the figure's right there in front of you. You don't have to search through the ebook to the next page or the previous page. So I really like having the book, but again, it's a personal thing. Some students really love just having that ebook.
And, and the other thing that I like about the ebook is you can highlight and then you can have it read out to you so that you can listen versus actually read. So I like that about the ebook, but there are apps now where if you have the hard copy book, you can take a picture of it and then it will read the text to you from your phone. So there's ways around that. If I would say, consider your learning style preference and the way that you prefer to study and learn is how I would make that decision.
Any other questions in that chat? I see.
Oh yeah, Salma, that's really nice. So Salma has another hard copy, an extra hard copy if somebody needs it. So you can reach out
Nice.
to Salma. Very nice. Any other questions that you guys have for us? Nothing at all. This is your time. This is your time because you guys are going to be going and taking the exam and
Yes, any questions about content, that you've had on your mind and have either been afraid to ask or whatever. I mean, this is the safe environment here. Ask here. You don't want to get to NCLEX and say, oh, I wish I asked them about this. So, ask us anything at all. We know there's so much to learn in the nursing, course curriculum. It's hard to know everything. And, NCLEX does realize that too. But, please ask us anything at all.
Linda, I was meant, oh, go ahead. Did somebody unmute? You go first. Maybe it was just feedback, but I was mentioning to them, I'm looking at their HESI exit results and they've got, let's see, this is version 2. So here's version 1. So we had a majority, like, let's see, 25, 35, 45, greater than 50% of the class needed further preparation based off of their version 1 results. Okay, and then the other half, they were better. So that was version 1. And then they've been studying since they took version 1. And now we're at we're still about 40% of the class needs further preparation.
Will they be taking another HESI after this review or no?
They take the HESI CAT on Friday.
Okay.
So it's not the HESI exit. You're familiar with these. It's a different HESI exam, but it is another HESI exam.
Okay. Well, I'm not sure if you saw this, but Angela, but just this past week, there was a publication from HESI, the most recent publication from HESI that
I
showed-
did. And I'm glad
Okay.
you brought that up because I was going to bring that up, but why don't you talk to them about that?
Okay, so what's really important is to know that HESI is very research-based, and they're always doing studies correlating NCLEX passing with scores on HESI. And so it's really important to have a score on that HESI greater than 900 to feel, comfortable and confident. And I'm going to go in there knowing that I've got what it takes to do this NCLEX and pass this. So if you didn't get a 900 or higher, then that tells you you really have to put a lot of prep time into getting ready. Can you do it and pass this? Absolutely. There's no reason that you can't. And again, we're going to talk more on Wednesday about how to prepare from here on in. But we're going to be telling you that you need to get in that comprehensive review book, and you need to get on the Evolve site because there's thousands of questions. And you need to practice at least 4,000 before you go into the HESI, the NCLEX. And you've been doing practice questions right along. So you can count those questions in the 4,000, but you need to do a question and answer approach to preparation for the NCLEX. You're not going to use your textbooks unless you need to read about something that you need improvement in or you're kind of weak in. But other than that, put your textbooks and all your books aside and focus on that Evolve site and that comp review book to get ready for the exam. And always read your rationales and your strategies because they will really help. And I don't know if you have anything to add about that study that was done, Angela.
What I will do, I'm going to look for it and I'll post it for you guys so that you can take a look, because I thought that was really interesting. Their findings that shows how important this is. Here it is, HESI validity results for NCLEX readiness. So this really helps you guys to know if you're ready or not. So I'll go ahead and put this in the chat so that you guys can maybe understand a little bit more about, why we harp on this for you. This is why, because we have actual evidence that shows that it's important for NCLEX readiness. And the other aspect of that is that if you do have to take the NCLEX again, your chances of passing after that first attempt significantly drop. And so we don't want that. We want you all to be nurses. So
Yeah.
and anything else on that, Linda? There were a couple other questions that came in. If you don't have anything else on the HESI topic.
No, no, I don't. But yeah, I know in this program and in other programs I've taught in, we harp about HESI.
Yeah.
But we do have the evidence, and we do know that, you need to perform in order to be ready for this examination.
Yes, exactly. Great. Okay. So there was a question, is it true that select all that apply has changed to it can be one answer or all of the answers?
Yes, that is correct. It could be
Okay.
one or it could be all of them. The maximum number that you will see for options is 10. No, I think it's 7. It's 10 for the new exam. But yes, all of them could be correct or one could be correct, unfortunately.
And do you know, Linda, I wasn't totally sure about this. I know for NGN, they're going to go to partial credit scoring for select all that apply.
Mhm.
Are they doing that for the current exam, or are they rolling that out with NGN? Do you know?
Yes, I do know they're rolling that out with NGN. So for now and for the exam that you're taking, you have to be right on with those select all that applies. But let me tell you, Angela and I have, and if you go, when you go on that Evolve site, you're able to select multiple response, which are the select all that apply. And there are hundreds of those types on the Evolve site that we've put in there for you. So go through all of them. And if if you can get those correct and understand those, you're going to be fine with those select all that apply. So we've given you lots of practice on all different topics. So, we highly encourage you that you get in there and do those multiple response questions. They're under alternate item formats. We can show them that when we go in on Wednesday.
And we will, and I have it pulled up, but I think we show them on Wednesday because we're going to show them everything at that time, and it'll be better, I think, to have it in one part of the recording so then they can go back and look at it later if they need to.
Yeah, I think one thing you could do some homework and go on to the Evolve site. If you haven't been on there yet, scratch a little code and get on and peruse around, because then on Wednesday you might have questions for us because you've looked at it, and we can tell you how to proceed through, because that will even generate a study calendar for you for your NCLEX, and we'll show you how to do that. But go in and take a look at that, and also go get the test plan off the NCSBN website if you haven't done that already. So those would be two important things.
And I posted that in the chat for them, so that should be pretty easy. So if you guys can just save it to your drive or to your computer, that way you'll have it.
That's great.
We got a question. What are your thoughts on also using UWorld for practice questions?
Okay, I don't know anything about that UWorld. I've never seen it, and so I can't comment on it. But what I can tell you is that I would highly recommend that you select whatever works for you. You select the one site, product, whatever, and stick with that line of products, because otherwise you're going to get overwhelmed and too confused. The other thing that I want to say, and again, I have no idea about UWorld, so I can't comment on it at all, but you need to make sure that whatever resource you're using, it provides you with rationales for correct and incorrect options and strategies for every single question. So we know the comprehensive review book does that. I'm not sure if UWorld or any other product does that. But just whatever you select, make sure it has rationales and strategies for every question.
And the one thing too that I would add to that just is that I think that maybe a lot of you guys haven't utilized the RN comp to its fullest extent, which you've already purchased as part of your level 1 bundle. So I would, you've already purchased that. So I would recommend definitely, using the resource that you already have access to. And then if you need something additional, then look for something else at that point in time. We have a really good question here. Would the test plan apply to us since the year on it says 2019 and it says effective from April 1st, 2019 until September 30th, 2020?
I'm not quite sure why it says till 2020. The only reason I can think it says that is because the NCSBN has changed the number of questions on the exam, and they've changed, let's see, what else have they changed? They've basically changed the number of questions. It used to be 265 as a max, and it's not that any longer. So that's probably why the 2020 is there, but the actual content listed in that test plan, yes, it does apply. They do a study every 3 years, and that's how they come up with the test plan and the activities that are listed there. The new test plan isn't going to come out and be available to us till January of 2023. So this test plan does apply to you. There's just some variations in numbers of questions due to COVID. And that's why you're probably seeing that 2020. But that is the test plan.
Yeah, I think that must be what it is too, because during COVID, they had to make modifications to shorten the exam to make sure that they could get test takers through with their physical distancing requirements. So they, to cut down on the amount of time needed to take the exam, they shortened the exam. So I think that's probably what it is too, Linda. So.
Yes, but the content is all the same. All the listings in there are the same.
Well, and maybe on that note, I'm wondering, since we do have just a little bit of time here still before lunch, we'll still give you guys a little bit of a longer lunch. I think you deserve that because we've been very busy this morning. But I think, what if I share the test plan really quickly just to show you guys? And I'm thinking, can you guys see the test plan screen?
Yes.
Okay. So I was thinking, if you search for activity statements, so you can even see here, which I think we'll go over a little bit on Wednesday too, but here's the distribution of the content for the NCLEX RN test plan. So you can see all of the different areas that you guys are going to be tested on. Some of this terminology might be like, okay, what does that even mean? Like, what are you going to ask me about with this, right? So then if you go to these activity statements, so search the word activity statement, and you're going to come to these boxes here. So within each of these major categories, you're going to see related activity statements from the practice analysis. And as Linda said, that practice analysis, what that is that's surveying of thousands of practicing new graduate RNs to see what activities are they performing in their practice during that first year. So this is how they come up with this list, and this is what they base their questions on. Some of these statements are very detailed, and some of them, are more broadly written, but it's definitely worthwhile going through the test plan, right? And just, okay, advanced directives, thinking about your kind of level of comfort if you had to answer a question about an advanced directive, advising, supervising client care provided by others, and so on. So there's within each major category of the test plan, I'll just go through.
See if you can find the laboratory.
Oh yeah.
Yes.
Yes. I feel like, yeah, here it is. Here we go. So under, even diagnostic tests too. See this, like ECG,
Yes.
O2 sat, glucose monitoring, fetal heart monitoring, non-stress tests, so on and so forth. And then for lab values, here's a list of the lab values that they want you to know. So you've got ABGs, BUN, cholesterol, and so on. So you'll know what labs you need to know. Okay, questions about that? When I was studying, and I think Linda definitely has recommended this, when I was studying, I highlighted the test plan. Can you see this Evolve site?
Yes.
Or no? Okay. So they were asking earlier about the lab value document, and since we just talked about labs, maybe I'll just show
Quickly
that to
show
them.
them. Yeah.
So you can go into any question. It doesn't have to be in any particular way. I'm just going to pull it this way. Okay. So pharmacology. And then if you were to, answer the question, then the lab tab is going to come up, and you'll have this here. Can you guys see this? Is the lab document up?
Yes, it is.
Okay, so, and then you guys can download this and keep this on your computer or whatever, make flashcards out of it. But it's 5 pages long. It's not crazy. But if you guys know these lab values, then you'll be able to pick out any abnormals. Let me see if we have other questions. Okay, so there was a question when we were talking about the test plan. Are those the only labs and diagnostic tests that we need to know? What do you think, Linda? Are those the only ones that they need to know, the ones that are listed in the test plan?
Well, you definitely have to know the ones listed in the test plan. And they listed those there for a reason, because those are the ones you're definitely going to be asked about. And what Angela and I did is went through all of the labs and selected those that we think you may potentially also be asked about. So what's on that lab data sheet, when you click on labs, if you know those, you're all set. Okay? Because there's tons of labs out there. So I would just, and do you have that lab sheet available or no? Can you quickly pull that up?
You want me to pull it up? Yep, yep.
Yeah,
I can.
because there was just one other point that I wanted to tell you about and share with you.
There you go.
Okay, so if you notice, if you know these labs on this lab data sheet that we've provided with every question, you're going to be fine. And refer to this as you're answering a question about a lab. You can click on that lab icon and pull this up, and that will give you experience and practice in learning. Now, just a really important point is on this lab sheet, you're going to see a lot of labs in parentheses, and you basically don't need to worry about that at all. Those are there because this book is also used in Canada, because Canadian nurses do take the NCLEX, but in Canada, they have to know what we call SI units. And SI units are the ones in parentheses. We go by conventional units. So if you just learn those conventional units, those outside of the parentheses, you're fine. So don't try to memorize everything else. Does that make sense?
All right, perfect. Any other questions? Just give it a few seconds to make sure nobody's typing a question.
Okay.
And just so all of you are aware, Devin has, let's see, he has posted the link to the next Zoom session in the chat. So what I'll ask you guys to do is, as we're getting ready to wrap this session up, to go ahead and hop into that next session. He's got the link here for you. It's also on the agenda. He's listed the passcode, although he believes that he was able to remove all of the passcode requirements. So hopefully it won't ask you for that, but it's there should you need it. And we'll have to move over to that next link for the next session, which starts at 12:30 with Miss Trinka for maternity. So I'm not seeing any other questions. So with that, we'll go ahead and give you guys 15 extra minutes for lunch, which is always nice. So we will see you in the next session. Linda, thank you so much.
Oh, you're welcome. We'll talk later.
Okay, see you guys soon. Thank you.